check 1 2. Sound check testing 1 2. Audio check. Sound check testing 1 2 2. Check 1 2. Check 1 2. Totally good.
Morning. How to move slides? How are you doing? Good. Well, good morning, everybody, and welcome to our next session for the Liver Connect. I'm Sammy Saab. I'll be a moderator this morning. We're going to hear two great talks in the first session. This is our faculty for today's two sessions. Dr. Bajaj from Virginia Commonwealth University, Dr. Charlton, Dr. Flam, Dr. Kolek, Reddy, Vargas, and Dr. Yunusi. This is an itinerary schedule for today. We're going to have two sessions. The first session will be with two speakers, and the second session, that starts at 9:30, will be 5 speakers. I think we're in for a big treat today. If you have questions, please write them down on the cards that should be right in front of you. These will be collected, and then we'll answer them during the discussion portion of today's talk. If you're on virtual, please submit your question via the question and answer section of the live stream viewer. There's accreditation, you've seen it before. And here are our objectives. We can describe chronic liver disease management recommendation guidelines for new treatments and describe current guidelines for diagnosis and management of gastrointestinal disorders. Another objective is to utilize new therapies that employ an evidence-based approach to management of gastrointestinal disorders to optimize treatment results for patients with chronic liver disease. And lastly, equally important, identify new advances and assess their potential impact on clinical practice. You will get an email for accreditation for CME units afterwards. These are the sponsors. Make sure we address and thank them. They're a big support. Without this Congress could not go forward. These include AbbVie, Dova, Gilead, Exelis, Intercept, and Salix. And in particular, our elite corporate sponsor, Mallinckrodt, Salix, and AbbVie Pharmaceuticals. And our corporate sponsors, Lexion, Gilead, Intercept, Siemens, and Quest Diagnostics. And other sponsors, Apex Clinical Solutions, Dova Pharmaceuticals, Ecosen, Sonic, Madrigal, and Fujifilm. So the first speaker to the session, Dr. Bajaj, he's from the Division of Gastrology, Hepatology, and Nutrition, Virginia Commonwealth University, and McGuire VA Medical Center, Richmond, Virginia. Dr. Bajaj?
Thank you, and thank you all for this invitation and for a chance to get out of Richmond. It's a nice city, but it's getting old. So I'm going to talk about refractory hepatic encephalopathy. By the way, there's no such word. It's persistent encephalopathy, but I know what you mean, and that's what I'm going to go with. So these are the grants and my PI and editorial board, and this is my institution has received grants. And I'm going to talk about fecal transplant, goloxanolone, and ornithine phenyl acetate, which are off-label. These are the learning objectives. 4 axes of HE management: understand the causes of refractory or persistent HE, understand the therapeutic options for refractory or persistent HE. So before we go any further, hepatic encephalopathy is brain dysfunction caused by liver insufficiency and or portosystemic shunting. It manifests as a wide spectrum of neurological or psychiatric abnormalities ranging from subclinical alterations to coma. So 2 things: you do not need to have cirrhosis to have encephalopathy, as long as you have a modicum of portosystemic shunting. Second, there can be many psychiatric abnormalities in HE, and many of them could be subclinical before the patient gets comatose. And this is the pathophysiology of HE. And if you look at the word hepatic encephalopathy, you assume there are only 2 organs involved, but it really takes a village to do this. You have the gut, which goes bonkers because the liver is not doing its job. It's not secreting bile. It does not have an access to the gut as it should have. So all these species that are now the policeman is away. The intestinal barrier is impaired. There are also these products from the gut that actually go through the portal vein, and they encounter a liver that is often inflamed. These make the liver more inflamed, which makes things a lot worse. In addition, the urea cycle is not doing this job. And we know two other organs, the skeletal muscle, which is a shame because that's the other organ that sucks up the ammonia from the system, and the kidneys, which are supposed to be net ammonia excretors, become net ammonia producers. And last, we know all of this goes to the brain through shunting directly or through the liver as well. And it affects the brain in multiple ways. All three major cell types, astrocytes, microglia, and the neurons are affected in the brain. That forms the syndrome of hepatic encephalopathy. So it's not really a complication. It's a syndrome that affects almost every part of the body. So what is the burden? The readmissions for encephalopathy, as people get more and more away from people who are, have variceal bleed, there's more and more hepatic encephalopathy. This is now even older data, but this has been confirmed again and again. Encephalopathy is the #1 cause of readmission, followed by infection, GI bleeding, and metabolic syndrome, which are metabolic complications. So these are really all precipitants of encephalopathy. So it's a problem. So what are the presentations of HE? One is covert HE without prior acute HE. Then you have the acute HE and the recovery from acute episode. We are going to focus on the acute and recovery from the acute episode because that's the definition of persistent or refractory HE. And these are the 4 axes I was talking to you about. Because it is so problematic for us to deal with the patient with encephalopathy, so many people need to be involved. You need to have people who are hospitalists, you have people who are inpatient facilities, and then you have the handover. This is the handover where most of the stuff goes awry. You have the inpatient team, you have the outpatient team. Often they don't talk to each other, and certainly no one talks to the patient and the family. Especially if it's the first episode of encephalopathy, no one takes the time. Oh, lactulose is cheap. Well, lactulose is cheap, but you know what? What is more expensive? Readmissions. So you want to actually make a lot of time to talk to the patients and the family members, especially if it is the first episode of encephalopathy, because that family is never going to be the same again. They deserve a little bit more of our time at the time of discharge. So you have type, grade, time course, and precipitating factor. So this is where we are. So what we talk about A, B, and C, most of our encephalopathy is cirrhosis associated. The grade we are talking about is overt. Grade 2, as you know, they're confused, but they're alert, but they do not make any sense. They have asterisks. Grade 3 is lethargic, but they can be woken up, and grade 4 is coma. So we are just going to talk about grade 2, 3, and 4. And time course, this is where most of the rubber hits the road. You have episodic, 1 episode in 6 months, recurrent, which is unfortunately most of our patients who keep on coming back. It's a revolving door. And persistent and recurrent sometimes blend into each other, but this is really the refractory forms of HE in which patients are just not functioning. Something or the other, you throw the kitchen sink at them and they are not responding, or they keep on coming back over and over again. And presence of a precipitating factor. So if you have a patient in the hospital, it's ideally you want to talk about the type, grade, time course, and precipitating factor. So you want to write that in the chart so that whoever the hospitalist is knows this was the precipitating factor now. You took the time to figure out what happened to the patient 6 months before, and then did your detective work. Is it the same precipitating factor that is coming again and again and again? Because this is a symptom then of the precipitating factor. And as we're going to talk about it, if the precipitating factor is not treated or inadequately treated, this can be labeled refractory HE. And this is a very complicated slide. I'm not going to go over all of this, but this is actually produced in partnership with the CLDF. But this is what you should be doing with the patient with encephalopathy, which involves airway management, making sure there are no other reasons for confusion, making sure you start them on adequate treatment like lactulose or rifaximin or hydration. And last but not the least, as we said, correct the precipitating factors. So what happens when you throw everything at the patient and the patient is not doing well? Still has what we call refractory or persistent HE. First, it may not be HE at all. Just because someone has cirrhosis does not mean that everyone who's confused with cirrhosis has HE. There could be logistic challenges towards medications. You gave them a prescription for rifaximin, but you did not hand them a bottle. You told them about lactulose, but they had 2 or 3 extra bowel movements and they stopped taking it. So these are the completely ridiculous, non-scientific, but unfortunately 2 common things that result in a costly readmission. Incorrect detection of precipitating factors and insufficient treatment of precipitating factors. Then you clearly have people who have persistent shunting with and without tips. And the minority of the patients are truly refractory HE. Most of these patients have some of these other things going on. So logistics of HE therapy and other medications. So the checklist at discharge, this sounds very boring, but it is not. It really, this is the number one slide that is going to reduce readmissions. Does the patient know the change in their prognosis and daily function? Most of the time they don't. Do the patient and the family member know sign of recurrence and ways to get in touch before the patient is comatose? Do they have a scheduled appointment for follow-up? Do they have medications to prevent HE with instructions in hand, not a prescription? Have potential recurrent precipitating factors been investigated? And last but not the least, it is hepatic encephalopathy. Are they candidates for transplant? So you need to have a short-term goal and a medium-term goal. There's unfortunately no long-term goal when you talk about HE. It's either something or the other's got to give at that point. So this is very important because if we don't follow this right now, we will pay the price later. So why is this an important thing? Because we live in our bubble. I'm not talking about the COVID bubble. We're talking about the bubble of tertiary care centers, where we have everything at our disposal. We have plenty of people to get on the phone to get pre-authorization. But what about when people are outside in the community? It was determined that more than 60% of patients did not receive ongoing prophylactic therapy to reduce the risk of HE recurrence after discharge. And this is really a problem because the more you reach in the outreach facilities, you realize that these things have just not made it, and you want to make sure that this is the case. And the NAXL cohort, which Hugo is also part of, and Dr. Reddy and several other people in the audience, we actually determined who comes back and where are the targets of improvement. This ranged all the way from patients, the precipitating factors not being detected, to patients actually getting aspiration pneumonia because they were not shifted enough. And what we found, if the patients who are on rifaximin alone, which is in the blue, and were readmitted, the rate of readmission with patients with lactulose, which is the orange and the red, is much, much higher as HE as the cause of readmission and HE during the readmission than rifaximin alone. We do not know the mechanism. Most likely it is because patients are either not able to tolerate the lactulose or they've not been actually given enough information about this. So these patients are often termed refractory HE because they're not really taking their medicines because we've not taken the time to explain to this. What are the other medications? PPIs, please withdraw if unnecessary. They're incredibly useful drugs, but only needed when they are only should be put in when the patients need it for the fixed duration. Opioids, please reduce the dose and frequency in these patients. Statins, continue, but do not start in people in decompensated cirrhosis. So if they have it, continue it if needed for their cardiovascular risk. Beta blockers also increase the risk related to portal hypertension. They increase, but if the patient has variceal bleeding, of course, they take preference. That takes preference. And other neuroactive drugs minimize gabapentin and benzodiazepines. You'd be incredibly surprised how many of our patients are taking things for sleep. And those are all the hypnotics, et cetera, we want to avoid in these patients because they come in with confusion. We assume it's HE. We give them everything, they don't get better. All they need is 2 or 3 days to literally sleep off their medication hangover. That's what it is. That it takes double or triple the time for those medications to take away. And so this is a big, big problem. So once these logistic things are taken care of, my feeling is more than 50 to 60% of what we think are the refractory people will become less than refractory, or at least reduce their ability to come back, their risk of coming back. What about incorrect diagnosis of HE? There are many things that are there together with the patient. You have diabetes. Diabetes is epidemic in our patients with cirrhosis. And you have so many other complications of diabetes that can actually be coexistent or labeled as encephalopathy. Alcohol, intoxication, withdrawal, as well as Wernicke's can all be a problem. Drugs, as we talked about, electrolyte disorders and intracranial bleeding and stroke. You clearly do not want to miss a stroke or an intracranial bleeding in these patients, especially if patients have risk factors for metabolic syndrome, which a lot of our patients do. If they have alcohol-associated liver disease, which again is always been a constant, but has become a big problem now. These can always be an issue and should always be taken care of. So let's talk about a case. And this is a 58-year-old man with alcohol-related cirrhosis, brought in due to dizziness, left-hand numbness, and not feeling himself. No seizures, headaches, or bleeding. 4 variceal bleeding episodes in the last 3 years, currently on propranolol. This is the blood pressure, pulse is 72, stupor, but no asterisks. Hemoglobin 6.4, reduced from 11 1 month ago. Platelet count is 23, creatinine 1.6, and ammonia, of course, was drawn, and it is 57. Our upper limit is 45, so big whoop. This patient is very confused. I don't know how the ammonia would help here. If it was 20, yes, it would have been, we would have thought something else. But 57 is chronic liver disease. Heme positive stools, no blood in rectum. So this is, the patient was admitted to HE, with HE, for GI bleeding. And some of these things do not make any sense. The massive reduction in hemoglobin, the platelet count, which was usually in the 70s or 80s or 100s in this guy, now is 23. With active bleeding, it should actually explode. It could go up higher. Creatinine is also increased. Was started on lactulose, GI was consulted. Exam 4 years later, patient was alert and oriented. No focal deficits, no bleeding. EGD was not performed. The patient actually had TTP. This patient had TTP, and he was admitted to the ICU assuming that this has GI bleed. That blood has to go somewhere. From 11 to 6, it didn't go anywhere. And I still remember this fellow's name who diagnosed this and prevented a whole, I was on call that day. So I particularly thank her. And this is extremely important. Of course, this is a unicorn. This is not even a zebra. But what I'm trying to tell you that these are patients who has cirrhosis, has had varicose bleeding in the past, has had HE in the past, but this one was not HE. And they were treating him as HE. And it was taking him away from a plasmapheresis, which is life-saving. Okay. So medications, again, we talked about little medications, but there's a lot of medications. This is Dr. Lewis in 2013 in Elementary Pharmacology and Therapeutics, wrote a beautiful review on opioids, benzodiazepines, and how their half-life is expanded in patients with cirrhosis and how long it takes for these patients to clear that. So what is not HE? New focal deficits, excitatory motor activity, current recent alcohol use or illegal or legal sedating drug use, and other situations. So we have to keep our wits about us when we are doing all of these things together and running our consultation service with these patients or running our inpatient service with these patients. What about shunts? Shunt diameter has been known for a long time to predict HE development. In this large study done on the Bovino Consortium, they found that the proportion of area of the spontaneous portosystemic shunt correlated with the amount of HE that was developing in the future, not currently at this point. But if a patient comes in with persistent encephalopathy, they're much more likely to have a spontaneous portosystemic shunt, especially a splenorenal shunt open. Embolizations of these shunts can improve the course of HE, especially with the low MELD score and a single shunt. What about TIPS? A lot of our patients get TIPS. So what is the overall all-comers risk of HE after TIPS? And what is the post-TIPS HE and how is that different? 25 to 45% get it. It's not an absolute contraindication that it used to be. 50% of readmissions post-TIPS are HE, can result in multiple episodes, and is the only reason why people have poor health-related quality of life post-TIPS. Almost every other group improves their quality of life after TIPS until and unless they develop HE. And what are the decision points? Older patient, prior overt HE, the current cognitive impairment, sarcopenia, advanced liver disease, and elective TIPS with alternatives. If you have an alternative, the risk is high. If the benefit is high, if it's urgent TIPS, younger functional patient, adequate social support, and adherent. Clearly, you do not want a patient who's put new TIPS in them and they live alone. So you do not have anyone to call the alarm when something bad happens to them. So this is a beautiful study done from multiple centers in France in which they randomized patients to rifaximin versus placebo. However, many of these patients were on lactulose before, they withdrew the lactulose, and post-TIPS, what they found, there was a reduction in HE in the patients who were given rifaximin compared to the patients who were given placebo. And this is it. So what about appropriate precipitating factor management? We talked about patients' logistics and medications. We talked about the patients being adequately diagnosed with HE and actually talked about shunting as well. But what about precipitating factors? There is a huge explosion of fungal and MDR infections in cirrhosis. So whatever worked 5 years ago may not work right now. Even if you're convinced that this patient has a UTI, even if you know that this patient has pneumonia, it's not 100% that precipitating factor is going to actually work with the medications that you prescribed to this patient. So it's very important to have the pulse of the antibiogram in your hand for your hospital, because this is like elections, all infections are local. You need to know your own infection profile in these patients. So multi-drug resistance and fungal infections are epidemic. Moreover, we assume there's going to be only one precipitating factor. There have been studies shown that patients have 2, 3, and 4 precipitating factors that may be interrelated, but may not be interrelated. So just because you found the leading precipitating factor does not mean that's the only precipitating factor if the patient is not getting better. So this is another case. This was given to me by the late Juan Cordoba from Spain. And this is a 68-year-old man with cirrhosis brought by family for 4 days of confusion. 2 weeks after UTI, currently is on ciprofloxacin. Varicose bleed 1 year ago with HE, not on HE treatment. Went to the ER at outside hospital, physical exam, stupor, arousable with verbal stimuli, non-comprehensible speech, which is his grade 3 encephalopathy. Temperature is okay, blood pressure is 98/60. It has asterixis without focal deficit or symmetric reflexes. This is the lab testing, CBC unremarkable. Sodium is little low, 126. Creatinine is okay, MELD is 24, and of course they did an ammonia, it was 129. The CT head was also performed, mild volume loss, so we know there's no bleeding, etc. happening. Urine and chest X-ray normal, blood and cultures, urine cultures were negative. Again, we talked about this, but what this patient had was a prostatic abscess. That UTI was never a UTI, it was a prostatitis. This patient, because they did the CT scan to look for shunts, they found this. So the assumption that you know everything about a patient's precipitating factor, most patients with refractory are not really refractory. They actually have some things going on. We just have to take some time, figure out what happened to them before, and figure out what else could be going on in these patients right now. So what about new and emerging therapies? Clearly, most of the therapies have been focused on ammonia. And not only ammonia, they've been focused on the gut production of ammonia. There's been remarkably little done towards the brain, and that's going to change a little bit. And there's been little done to the muscle, at least in the United States. L-ornithine and L-aspartate is available, and branched-chain amino acids are available outside the US, but not in the US. Then we have the ammonia scavengers, which are the stuff that sucks up the ammonia that has already escaped the gut into the system. And this is fecal transplant. I'm not going to belabor it, but in smaller studies done by our center in enema, as well as oral capsules, the fecal transplant shows good proof of concept that in patients who are already on lactulose and rifaximin, and if they're still cognitively impaired, this is not only safe, it potentially can improve outcomes. We are doing a larger study right now with going to have 60 to 70 patients, which is phase 2 with oral versus enema, and we've 1/3 improved. What about the teeth? You fix the teeth, their brain function gets better. So please fix the patient's teeth, and the teeth, open their mouth, and don't just wait till they are actually getting transplanted. These are patients, all you need to do is go to the dentist, then the patient has to do whatever they need to after that. You don't have to do anything else. Just tell them to go to the dentist and that's it. You don't have to do anything. And no one is going to fault you for sending a patient to a dentist. That's what they're supposed to do. If they're edentulous, the time has passed, of course. But this is, when we did cleaning in patients with cirrhosis, their cognitive function improved. Not only that, their quality of life improved, their microbiome, the saliva, and the serum improved as well. So what about ammonia scavengers? Remember, I talked to you about new therapies. This is ornithine phenyl acetate. This is a study that was done at great effort across several countries. And many of you are co-investigators here. What we found in this study, that it improved it, but not to the extent that you wanted. It did not reach the primary endpoint. So you needed to have hyperammonemia that was verified in a patient who came in with overt hepatic encephalopathy that did not get better in 12 hours. At the end of 12 hours, you either randomize them to placebo or multiple doses of ornithine phenyl acetate, which is basically sucks up the ammonia and has the patients excreted as PAGN. What they found is P was 0.129 when all comers were taken. But then we realized that a lot of the ammonia, and this is the problem with ammonia, a lot of the ammonia measurement outside in the hospital was not reliable. So around 30 patients were admitted who were never hyperammonemic. So if you excluded those patients, this trial was highly statistically significant, which just tells you all ammonia is not the same. You have to have a set threshold beyond which the local lab changes happen, because that result in this trial being so close. That's the type of the title is so close is because of the second part here it was not them. What about the brain? Remember I talked to you about for an encephalopathy, very remarkably little attention has been paid to the brain. Beyond flumazenil, that was all the rage 20 years ago, which actually did not come out to be much in human studies. It actually increased the risk of seizures. This is another thing that actually focuses on neurosteroids, which engages GABA, the inhibitory transmitter. And what they found that in this study that is online now in Journal of Hepatology, goloxanolone is well tolerated with a positive effect of EEG indices, subjective sleepiness on reaction time stability as well. So this is a nice proof of concept. They're now starting to do a larger study in this thing, but it's exciting to know that all aspects of HE, not just the gut, are being focused on for it to get a true syndromic nature for what it actually deserves. So again, management of refractory ascites, it's actually incorrect diagnosis of HE. You want to make sure that it is truly HE. Incorrect detection or insufficient treatment of precipitating factors, and take care of persistent shunting in these patients. And thank you all for your time.
Thank you, Bajaj. That was a wonderful talk. To remind everybody, there are some index cards in front of you. Please write down your questions and pass it to the young people that are collecting them. We'll have some time for questions and answer at the end of the next talk. So the next talk, it will be about Dr. Hugo Vargas here at the Mayo Clinic in Phoenix, Arizona, who will be talking to us about another major complication of cirrhosis. His talk is entitled The Puzzle of Hepatorenal Syndrome Management. Dr. Vargas?
All right. Thank you, everyone, for being here. To the people online, thank you for participating in this, and thank you for the invitation to participate in this final live event. This is very invigorating. It's very fun to be here in person. I hope that you realize how much your presence actually highlights how much I missed all of you, whom I saw very frequently in other venues. My disclosures are here. I omitted to mention that I was going to talk about terlipressin, which is technically off-label in the United States. So many of you on the audience may not find it to be off-label, but that needs to be also disclosed. We've been doing a lot of memorializing in the area of hepatorenal syndrome and portal hypertension. I want to bring to memory a giant in this area who's inspired us to go through this process of trying to combat hepatorenal syndrome that continues to be a problem. Dr. Boyer died a few years ago, but his spirit and his passion for portal hypertension management remains. So I want to pay tribute to him in the discussion of hepatorenal syndrome. My objectives for you today, as the title alludes to, is I want to really talk about the difficulty that we have in defining acute kidney injury in the setting of liver disease, the misunderstanding of what really is significant, and to define strategies that will help you to address this, particularly in view of the fact that we still don't have the optimal vasoconstrictor regimen in this country to address the problems that we have to deal with in this patient population. And I really want to make sure that we understand fully how impactful acute kidney injury, and particularly that version that is defined as hepatorenal syndrome, is on patients who are awaiting liver transplantation, because it is extremely important for us to be aware of that. And I realize that it may feel like I'm bringing coals to Newcastle when I talk to you about this, because you all know this, but it's very important that we begin to think about how we let other clinicians who touch our patients, who may misunderstand what's going on, get to the treatment of hepatorenal syndrome, of our acute kidney injury in our patients quickly, so that we can address the reversal of that process and impact their survival. This is particularly germane to this slide. All of you know this. Creatinine, particularly and normal creatinine, is not normal in our patients. It overestimates renal function and underestimates the risk these patients have. So a cirrhotic patient with a quote unquote normal creatinine is not normal, as you all know. I mean, these patients are in significant renal insufficiency. However, our colleagues, the hospitalists, the residents, the outlying community clinicians that don't see this every day don't know this. Remember this. Send that message out when you hear about a patient whose creatinine is 1.2. You want to find out what's the baseline, and please send this patient over, because this patient may already be in renal failure as far as we're concerned. This slide also is already getting a little dated, but it's still very important. So when we hospitalize a patient with cirrhosis, a significant proportion of those patients have acute kidney injury, about 20%. Within that population, some of them, 30% or so, have chronic kidney injury, and keep this in mind because they can develop acute kidney injury on top of that. And I'll highlight that in a little bit. And then the vast majority of those patients are going to be volume responsive. So one of the things that you really want to think about is how are they doing hemodynamically and what can I do to optimize volume intravascularly to see if this is a reversible process. And it's really the patients who don't respond to volume rescue, those patients, and this is again dated because this is talking about hepatorenal type 2, which is not the case anymore. The vast majority of those patients are actually the ones that we want to focus on trying to return them back to normal and prevent the grim outcome of hepatorenal syndrome. Unfortunately, the slide doesn't really get projected very well, but what I wanted to bring out is that we were all taught along the center line about portal hypertension related renal dysfunction. So we know about all the hemodynamics of renal disease in the setting of cirrhosis and know how we activate the renal angiotensin aldosterone axis. But let's begin to really bring into this picture the stuff on the right-hand side of the slide, which reflects the fact that the portal hypertension isn't just affected by the hemodynamics, but it's also affected by the fact that we have inflammatory responses in the body, both from infectious or damage related, the so-called DAMPs and PAMPs, that will enhance the hemodynamics that cause hepatorenal syndrome. And also on the left-hand side of the slide, we need to remember the sicker the patient gets with advanced liver disease, there is cardiovascular dysfunction inherent to cirrhosis that also adds to the hemodynamics of hepatorenal syndrome. And just to remind you that of all the causes of renal failure and cirrhosis, hepatorenal, aptly labeled here in red, is the most lethal. So we've got to really act. And those patients that don't have transplantation as an option actually are really not going to survive for very long. And they're really confined to hemodialysis, which is not a great option in the end of life situation. So part of the puzzle is figuring out when do we have hepatorenal syndrome. Traditional criteria, which many of us use still in our minds, is a 50% increase in serum creatinine over a baseline. And we use this cutoff value of 1.5 milligrams per deciliter, which is important, but it's not the end all be all. The new definition, the AKI network definition that's endorsed by EASL and that we will endorse also in our community, is that an increase by 0.3 milligrams per deciliter, that's not a huge increase, particularly if we know the baseline on our patients, or an increase by greater than 50% from a baseline that you should know. Again, the message here is know the baseline creatinine in your patients, document it so that when we look at these patients in the setting of an admission to the hospital, we'll know if they are in renal failure and make the best effort that you can at gauging what that baseline creatinine should be. Furthermore, we need to stage those patients. And there's actually several stages very clearly defined. Again, stage 1 is that increase by 0.3 milligrams per deciliter or an increase in serum creatinine baseline by 1.5 to 2-fold from that baseline. And this is where I mentioned that the 1.5 milligrams per deciliter was important. You can subclassify this in 1A or 1B based on whether you reach that threshold, and I'll show you why that's important. Furthermore, once you have increases that are more significant than the 2 to 3-fold at stage 2 or an absolute serum creatinine of greater than 4 milligrams per deciliter, those are the stages that you need to consider. And I think that taking action on this type of patient really is relevant to understand what stage of the disease they're in. Data from Italy and from Spain highlights how important the staging is. As you can see here, the probability of survival or the mortality on the right-hand side is much greater depending on the stage. If you see here, and unfortunately the colors don't show very well, but the blue on the right-hand side will show you the mortality for those who have serum creatinine less than 1.5 milligrams per deciliter absolute is not very significant and is not very distant from those patients who have no acute kidney injury. So that's where the staging matters. So if the serum creatinine is greater than 1.5, even though it may be still stage 1, pay attention to those patients because they're actually going to potentially have a worse outcome. And obviously stage 2 and 3 have much worse outcomes than stages 1A or 1B. Why does it matter? if we have patients who we have listed for transplantation, this is a very nicely curated list from patients listed in the United States from 2007, 2014, where there was an effort at defining whether the patients had chronic kidney disease, meaning that they had greater than 72 hours worth of hemodialysis or underlying decreased GFR or acute kidney injury, or they were normal, right? So if we look at their outcomes regarding mortality on the waiting list, as you can see here, above and beyond chronic kidney disease, which portends bad outcome from the normal, acute kidney injury in addition to chronic kidney disease or by itself increases the mortality in this patient population. So these are patients that we can rescue, but imagine even in that situation, these patients have a very much higher mortality on the waiting list. Dr. Piano published information from Italian patients who were transplanted. And it's very important. You should look at this paper. Patients who had acute kidney injury defining hepatorenal syndrome, receiving a liver transplant, those who did not respond to terlipressin therapy were much more likely to require renal replacement therapy after transplantation. I mean, look at that, 0% of those patients who responded went on to RRT after transplantation. And non-responders to hepatorenal syndrome treatment had a much higher incidence of chronic kidney disease at 1 year after transplant. So non-response to terlipressin and albumin was an independent risk factor for chronic kidney disease at 1 year after liver transplantation. Important to really recognize that the earlier that we treat and the likelihood of exposing patients to effective therapy is going to lead to better outcomes, even with transplantation, which is the key to treating these patients. So when is acute kidney injury hepatorenal syndrome? First, you have to have a diagnosis of cirrhosis, obviously. You have to have this diagnosis of AKI per the AKI network criteria, which I highlighted to you. You have to see no response to 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin. And I'll touch on this a little later. You obviously have to have a patient who's hemodynamically rescued and not shocky, get rid of all nephrotoxic drugs, and then make sure you have no structural or post-renal reasons for the renal failure, which you can do in a very rigorous approach to this patient population. So the next piece in the puzzle is management, because we don't have a complete regimen of treatment in this country. We want to avoid renal replacement therapy. That is the real goal. So improve any options that we have to prevent dialysis, facilitate medical management, hopefully return this patient who technically is decompensated to a compensated state, decrease ICU stays, and for those renal transplant potential candidates, remember, less renal replacement therapy prior to transplantation means less likelihood of chronic kidney disease after you're done with the transplant and improve survival. So even if you have transplant, they live longer and they live better lives if you treat their acute kidney injury. So this is a fairly schematic way of approaching this patient population. Obviously, you want to assess what's going on with the kidney injury. You want to do close monitoring, particularly if it's in their stage 1A, which is the green here, and monitor to see if there's resolution. If there's persistence, you can use clinical judgment to decide whether you go and treat them as aggressive, progressive disease, or wait a little longer. And obviously, if they're progressing, you need to very quickly, if you haven't done it already, withdraw diuretics, begin albumin expansion. And if the patients respond, then continue to monitor. If they don't respond, then you have to ask yourself, is this patient hepatorenal? And then if they do seem to be that, then you start thinking about vasoconstrictors and albumin. This doesn't have to take hours or days. It can be done very quickly after admission. Very aggressive management is the rigor here. So the first thing you do, we have to volume replace. IV albumin should be given in a reasonable fashion. Use your judgment. 0.5 to 1 gram per kilogram, maximum 100 grams per day for resuscitation, then 25 to 50, and use your judgment. If the patient's fluid overloaded, don't overload them more. Vasoconstrictors in our population, unfortunately, terlipressin is not an option. It's not approved in this country, but midodrinotriotide have been used. Norepinephrine can also be used. Unfortunately, in most of our settings, this will require that the patient go to the ICU. Why am I mentioning albumin here? Most of us think of albumin as an oncotic pressure agent that facilitates volume expansion in the vasculature. But remember, this is an antioxidant. It solubilizes a lot of material that our body is handling. It stabilizes the endothelium, has hemostatic effects. and improves capillary permeability. So it's very important that we keep in mind that this is an agent that is not just a supplement like you would use saline, but it's a very important physiological agent to use in the setting. And how do we figure that we've actually succeeded? A complete response is, again, a creatinine that's within 0.3 milligrams per deciliter of the baseline value, and a partial response is everything that is close to that, but not quite there. And you know, the reality, we've found this in doing clinical trials with terlipressin, that this recurs, and we had built-in parameters for retreating because this can actually happen. This is a meta-analysis that looks at the fairly limited data that's available for us to assess the use of either nothing or a vasoactive agent. But you can see here, the impact on the short-term mortality is limited because there's very few patients, and there's really been very limited head-to-head therapy that has been documented in the literature. But the reversal of hepatorenal syndrome is really evident with terlipressin, with norepinephrine, and to some extent with dopamine. But the reality is that we have very limited data in this respect. And I think terlipressin turns out to be probably the most likely agent that will help us to improve this. I want to leave you with this as a mental image of what you are dealing with. I mean, terlipressin compared to midodrine, which is what we usually use in our country, is pretty dismal. I think that we are really truly dealing with midodrine octreotide as a placebo here when it comes to actually treating patients who are true hepatorenal patients. And even in the setting of a patient transferred to the ICU when you're using norepinephrine, the impact is not as significant as when we're using terlipressin. So I think that we need to keep in mind that the options that we have currently are not optimal. And I want to encourage all of you to be advocates to ensure that our regulatory agencies understand that there's data out there already that makes it very clear that with judicious application of the right agent, we can actually reverse this. And so we have to advocate for our patients. And I want to give my kudos to the board here at CDLF, because we've been trying really hard to enforce that message across. And as a community of hepatologists, we're trying to change the course for patients who have this disease. So terlipressin, I touched on this. This is a synthetic vasopressin analog. It's a prodrug that will release the agent slowly, so that there's an advantage over giving vasopressin as an infusion. It's administered IV. Typically, the treatment can be 6 to 14 days, depending on how you're using it. In some countries where it's been used for many years, it's actually used by the EMT crews when they see patients with complications of portal hypertension. The process for trying to get the phase 3 program moving through this country is outlined here. As you can see here, many of us have been working at this for decades, trying to get this drug to be approved. And the most recent publication in the last month, I think, in the New England Journal of Medicine, the CONFIRM study, a study that enrolled 300 patients randomized 2 to 1, as you see here in the schema. The demographics, as you can see here, enrolled patients that were very similar in presentation, high MELD scores as you would expect. ACLF grade was about 20% in those patients, and the mean bilirubins were between 13 and 15 in this patient population. So they were looking at primary endpoints that were complex. I mean, this is a complicated primary endpoints, but it really essentially looked at 2 consecutive creatinine values of less than 1.5 milligrams per deciliter collected 2 hours apart. No incidence of renal replacement therapy 10 days after the second confirmatory creatinine. And then the patient had to be alive for 10 days after the second confirmatory serum creatinine. As you can see here, terlipressin reached that endpoint at a rate of 30% as opposed to 16% for the placebo patients. And secondary endpoints, which I think are all very impressive. Hepatorenal syndrome reversal with serum creatinine back to less than 1.5 milligrams per deciliter, durability of hepatorenal syndrome with no renal replacement therapy for 30 days, and hepatorenal syndrome reversal in patients with SIRS physiology. All of them were statistically significant. There was a trend towards no recurrence of HRS by day 30, but that did not reach significance. A subgroup analysis looking at patients who were transplanted in this patient population. You can see here that the incidence of dialysis after liver transplantation was twice what it was in the patients who received placebo. So again, the durability of therapy, confirming again what Dr. Piano presented, was seen in this patient population. So by subgroups, very important to realize patients who had ACLF or serum creatinine that was greater than 5, very sick patients, tended to not benefit from this. But if the creatinine was between 3 and 5, you could still get a significant improvement. Patients, as I mentioned, with SIRS physiology, low baseline mean arterial pressures, patients with alcoholic hepatitis presenting with hepatorenal syndrome, all benefited from treatment. So I think it was a very impressive set of results. The most common adverse events occurring greater than 10% of the time, we knew this one's going in. There were problems with abdominal pain that called to our attention the possibility of vasoconstriction in the splanchnic circulation, vomiting, hepatic encephalopathy. This is very common. The things that have become very problematic to us is that we did discover a very significant difference between patients receiving terlipressin and respiratory failure. And of course, you can see here multiple organ dysfunction syndrome was more likely to be seen in the terlipressin group. I think it's very important to keep in mind that in this patient population, there may need to be a very careful selection of the patients that are going to go into therapy, and I'll touch on that a little bit more. So the risk management for this patient population, if we were ever to begin to use terlipressin, we need to optimize the benefit and the risk for each patient. We need to avoid treating those patients who have very high creatinines or maybe too far for us to respond, or patients with multi-organ system failure, such as those patients with ACLF grade 3. And I think that hopefully this way we will address things. I think that one of the points that I want to make sure that I double emphasize is that by using the AKIN criteria for diagnosis allows us to much more readily diagnose this before patients get to this point. I think that there's a continuum, and I think that if we try to educate our referring clinicians and to begin to think as we treat our patients, that the earlier that we address renal dysfunction in this setting, the more likely we are to improve things, I think we're going to succeed. We need to protect the airway. We need to treat hepatic encephalopathy very, very aggressively. We need to do more nuanced management of fluid balance. And we need to probably not treat these patients who have pulmonary edema or pneumonia as a way to prevent problems with the pulmonary injury that we see. So how do we work the strategies? We need to prevent hepatorenal syndrome. What can we do? We know albumin administration after large volume paracentesis reduces the risk of post-paracentesis circulatory dysfunction. I think that's important to really enforce as we plan on treating our patients. Let's prophylax our patients against SBP, because remember, infection triggers hepatorenal syndrome and causes mortality. Patients who are given albumin in the setting of SBP will less likely proceed on to hepatorenal syndrome. Let's do this. There's some data, the jury's still out, about chronic weekly albumin administration and decompensated cirrhosis in patients with ascites, but more to follow on that. I think that we should think about ways in which we can improve the patient population we're treating to prevent HRS. So to conclude, I want to leave you with the fact that HRS is a common complication of decompensated cirrhosis, is associated with high mortality in a very critical population. Vasoconstrictor therapy is the mainstay of therapy. I'm hoping that we can all work together to try to approve this medication regimens here in this country. Liver transplantation is the definitive therapy, but remember that the patient who goes into transplantation without dialysis does better. And the shorter the duration of dialysis in that patient population, the better for the patient. And the reversal of HRS pre-transplantation is associated with improved outcomes. I hope I've convinced you of that. Thank you very much.
So we're going to ask our speakers to come up for the question and answer period. First, before I begin, I want to recognize Zubair Yunusi. I mean, he's been an incredible leader for the CODF, and this wouldn't be possible without his guidance and leadership. And also Steve and the Focus Medical Group. I mean, all the little things you see that we take for granted, they're responsible for that. So thank you, Steve, and the Focus Group. We're a little bit ahead of schedule, and hopefully they give us more time for question and answer. So I'll go through some questions here. The first one is for the encephalopathy talk, Dr. Bajaj. And the question is, why do PPIs increase the risk of hepatic encephalopathy?
It's not a direct, it's a epidemiological studies in people who have PPIs. The underlying hypothesis is that it's dysbiosis as well as infectious complications. that could make these patients much more liable to develop encephalopathy in the future. And these are studies done in large cohorts. So, but again, I'm not anti-PPI. I'm anti using them longer than necessary or in patients who don't need them at that point.
Another question for Dr. Vargas. When someone's admitted with suspected acute kidney injury, how long do you administer albumin for? And what is your end game?
You know, that's actually been a kind of a shifting process. When we started doing our hepatorenal trials, we recognized that albumin replacement in patients who were very well curated and classified as hepatorenal is very helpful, and it can reverse hepatorenal syndrome quite well. The problem that we've encountered is I think that we've gotten to be so dogmatic about using albumin that we don't really give good guidance as to when to stop. Again, 2 days worth of at most 100 grams of albumin, or using the guidelines of that I gave you here, will help you. And I think you should probably follow the patient's albumin carefully, so that when you're reaching a point where you have a normal albumin in the patient who's hospitalized, you probably should kind of de-emphasize that. But I do think that intravascular repletion is very important.
Yeah, because it was the second paper in New England Medicine that highlighted that too much albumin was bad.
Correct.
And we need better assessments of volume status.
And I think that you know, to reemphasize that, I think that one of the concerns is that a lot of the morbidity and mortality you see in the patients who are receiving terlipressin is really related to pulmonary complications that may be triggered by over volume correction.
Oh, thank you. Oh, thank you so much. I have a question for both speakers. Are ARBs or ACE inhibitors contraindicating patients with HE or HRS patients? Did Josh know? Not for HE and for kidney?
I would proceed with caution, because you know, ACE inhibitors and ARBs can impact renal function. I think that if you're doing it for a good reason and monitoring the patient closely, I don't know that they are contraindicated as such. But again, in a patient who's got renal injury in the setting of decompensation, I would be very, very cautious with anything I introduce that could be renal toxic.
Okay.
Same again for decompensated cirrhosis. All bets are off for all of these medications. So because you have to then reassess, what are we preventing here? If the patient is very decompensated because of cirrhosis related conditions, then a cardiovascular event really is not going to take them out. So you want to make sure that whoever's starting it has a full understanding of the overall prognosis of the patient and discusses it with the hepatologist, like before initiating anything. And this becomes especially true for the new diabetes medicines, you know, not new anymore as the SGLT2 inhibitors, because many decompensated patients with cirrhosis are often, they say, why should we start this in these patients? And the answer is, it's not a yes and no for every patient. So we've had that thing with the endocrinologist discuss it with us before they just slap it onto a patient, which is good.
All right, thank you. Another question, Dr. Vargas. Hugo, if you had a crystal ball, do you envision terlipressin to be used outside the ICU, or would it be as an ICU-based therapy?
Oh, that's a very loaded question. I think the advantage of having something like terlipressin in our clinical trials, we did this outside of the ICU. It's a very safe drug. I think it is, you have to be judicious and you have to know how to use it. I think the last thing I would want to see is approval of this and being limited to ICU care, because that's what stops us from actually using vasoactive agents. I mean, once the patient's in the ICU, you lose control of all of the things that can be done with this patient. So I think that having early access, I envision having it at the outlying hospital where the patient's being managed before I see them and I can guide them. But it becomes very difficult if it's an ICU related drug, because then all of a sudden the door closes to the ICU and you don't have access to this drug.
There's been a recent very provocative trial on norepinephrine outside the ICU in Stanford. It just came out in liver transplantation.
Wow.
So, but you know, just saying that we would want to ideally give these drugs out. The reason why that was done is because, but as Hugo says, once they're in the ICU, you have a different set of stakeholders and drivers that come on board, and you know, you really kind of not. So anything outside the ICU, like we did in the confirmed trial, is
Excellent. So here's a question, Dr. Bajaj, and this comes up at almost every meeting, every presentation, is the role of ammonia. And the question verbatim is, do you ever check ammonia levels inpatient or outpatient to monitor and or prevent HE?
No. I do it in patients who I truly have a problem. If someone is comatose and the ammonia level is 20, then that is helpful.
Okay.
But if someone is confused and the ammonia level is high, doesn't add a whole lot to my inclusivity of it's a very good exclusionary test if someone has a normal ammonia in the setting of confusion. But if someone is awake and alert, they could have a high ammonia. If someone is confused, they could have a high ammonia as well. So I certainly do not trend it, because once we have made the diagnosis of HE and it's clear in our mind, we follow the clinical status of that patient more because of the lability of the ammonia.
Okay.
So as I told you in the ornithine phenylacetate trial,
Mhm.
the most curated ammonia measurements also failed to actually get patients who were appropriate for the study. And that was a clinical trial.
Yeah.
And another potential clinical preparation for a clinical trial that was done around 8 sites found that the ammonia levels were so variable between the 8 sites that it actually were almost unusable to actually rule someone in or outside of a clinical trial if ammonia was your endpoint.
Yeah.
So
I mean,
very labile.
how is for better biomarker?
Yes,
Of hepatic encephalopathy.
so that we calls for better biomarkers. Right.
So, Dr. Charlton, you have a question?
Yeah, a question for Hugo. So if you look at creatinine, terlipressin would have been improved years ago, of course. But if you look at survival, which the FDA does, it's not approved, which is our current state. How do you see terlipressin getting to the point where we can identify patients who don't benefit or are harmed by it, or minimizing the side effects that lead to the mortality differences we see?
Maybe repeat the question or summarize it.
So the question, Mike, is the concern is that the creatinine alone doesn't drive the decision by the FDA, but it is the concerns about all the collateral damage you can cause in this
Yeah,
setting.
it doesn't improve survival at all.
Well, I think if you look at the data, it definitely returns patients from hepatorenal syndrome back to normal creatinines, and there is a hint that there is improved survival. I mean, I showed you a meta-analysis. I think terlipressin can, in comparison to placebo, improve survival minimally, but I do think that the management is quite complex. I think if you can avoid dialysis, if you can take a patient to transplantation without going to renal replacement therapy, there's definitely plenty of data that it actually will help. I think that it's difficult in a situation where the patient's not a transplant candidate, and I wonder whether there's actually some limitations to that. But I do think that the data that is indirect from the fact that if a patient doesn't go to dialysis and if they respond to terlipressin, they actually will do better after transplantation, is pretty compelling to me to proceed using this.
So another question, a very practical and very important question, Dr. Bajaj, is after TIPS, what is your frequency of monitoring patients for encephalopathy? What's your frequency of doing ultrasounds for TIPS stenosis? I mean, how do you manage these individuals? Do you put them on rifaximin?
We don't put them, currently it's not approved, it's off-label. So we do not start any prophylactic treatment for TIPS for encephalopathy, but we do a lot of counseling for these patients, not only, especially we are talking about elective TIPS. We're not talking about urgent TIPS where you need to save the patient's life. Now, all those things are changed. So in elective TIPS, especially when you have alternatives, you give the patient the alternative. And many patients have actually said no to TIPS because of the possibility, 30% possibility of getting HE in the past when they've never had it before. So once you've counseled the patient or they're tired of the LVPs, or you've told them the survival data with TIPS is better and they go for it, we want to make sure that there's a caregiver. We don't have a set stenosis kind of guideline for those patients because the IR typically drives that. And we usually just make sure that you add the Doppler even you're doing the HCC screening for those patients. But clearly this is important to make sure the patient is nutritionally optimized. Is if they're on HE, they should be on HE treatment. We don't start them on prophylactic treatment, and they have caregivers who can call us if and when something bad happens.
That's excellent. So Dr. Gillen?
Thank you, Sammy. When I was a fellow in London with Professor Sherlock, we showed the ammonia tests were a total waste of time unless they were done fasting, resting, arterial, and collected on ice. And I do not believe a single test in the United States is ever done under those criteria. And hospitalists and internists in the United States do 3 or 4 times a day ammonia tests, and they're just being a lovely contribution to the pathology department. Would you like to comment on that, please?
So
I totally agree. I was like, it's a resonance.
But I don't know where the residents get their information from. They keep on ordering pneumonia levels, primary care doctors order pneumonia levels.
Is
They
the
give me
ER?
lactose based on a number. I don't know where
Is
they get
the-
the information
is-
from.
I do not know. I know if I were a patient, I would not want to poop my guts because of an ammonia level constantly for the rest of my life. And someone asks you why, they're like, oh, I do not know. Or you are encephalopathic. What do you know? And then it's impossible to take it away because if
Yeah.
something bad then happens to the patient. So we just seem to be operating in a space where we have ammonia and we have PPIs. These are the two things that are basically plaguing our patients, unnecessary overuse of one and unnecessary overinterpretation of the other.
Another question, please.
I want to reinforce what Norm said, that in the old days, we used to obtain intra-arterial samples for ammonia. And the game didn't end then. The syringe had to be corked, so to prevent oxygen from getting into the blood because metabolism continues. And it had to be kept on ice until it was actually assayed. We don't do that anymore. Everything is venous. And I cannot remember the last time I requested an ammonia level. So the methodology used today is not geared to get you the real answer.
Yeah.
The other question I want to ask Hugo is when you have a patient who has improved in his renal function and perhaps come out of HRS or is borderline, aren't these the grounds for doing both liver kidney transplant at the same time?
Repeat the question.
So the question is, when do you proceed to do a liver and kidney transplant, simultaneous liver kidney transplant? There's very clear guidelines that you actually have to have a prolonged period of renal failure to be able to qualify for that. And as a matter of fact, UNOS creates a promise that if you attempt to transplant a patient with liver alone, despite renal dysfunction, that you will be able to rescue that patient should they proceed to chronic kidney failure within the first year after transplantation. So I think the incentive is to prevent the simultaneous liver kidney transplant in that setting. So, and I'm hoping that the reality is you don't have to transplant those folks, because if they're truly HRS, they will continue to have normal kidney function post-transplantation.
Thank you. The question in the back, please. Yes.
Yeah, question for Hugo. Hugo, how do you account for the potential insensitivity of the serum creatinine and disparities, particularly as they pertain to differential muscle mass in men versus women, or the presence of concomitant profound sarcopenia, where a serum creatinine, it does not potentially reach that threshold of 1.5, and yet a patient has more profound renal impairment than the thresholds reflect?
Yeah. I think you're right on target with this. I think that the concern I always have is that it's really important to know what a baseline creatinine is for those patients. In other words, the greater the effort you can at knowing exactly where you are. In our unit, we tend to use cystatin C as a better measure of renal function in that patient population. It's not built into the guidelines, but I think if you look at a patient who has a creatinine of, say, 0.7 2 weeks prior to admission, and the patient now has a creatinine of 1.1, that patient's in more trouble than meets the eye. And I think this is where people in the community don't quite capture that. I mean, these patients who are very advanced, very sarcopenic, will not have creatinines in the normal range for an adult of their age and size.
So another, going back to crystal ball, when you foresee telepresence being available to physician providers?
That is not in my I mean, my crystal ball doesn't extend that far. I think that I'm hoping that the agency will. I mean, I know that Mallinckrodt is working very closely with the agency to make sure that the CRL is actually enacted into approval of the drug with conditions that will hopefully help our patients and minimize injury to those patients who don't benefit from telepresence.
So a question for Dr. Bajaj, and this is regarding spontaneous shunts. Do they behave differently from non-patients with HE without spontaneous venous shunts? And what is the role of CARTO for HE embolization?
So the embolization is clearly an option for patients who have like mostly a one dominant shunt. That having been said, our IR cowboys, I sent them,
Yeah.
they did 17 shunts on one patient. Thankfully, that patient, it's embolizations, I mean, not shunts. They basically, the patient thankfully lived to tell the tale afterwards, but you have to be careful. People can go overboard. So you want to just ask them how many shunts there are, how many actionable shunts there are. So the patients do behave differently, yes. The more shunts someone have, it's just another way of measuring portal hypertension, really. And if those patients have, are much more likely to have persistent or refractory HE. And I always err on the side of doing this, especially if the patient's MELD score is less than 15 or 11 is the traditional study, but we go over 15. Because if you remember, these are the patients who are not going to get a transplant anytime
Right.
soon. And you want to make sure they don't come back to the hospital. They don't get a fall.
Mm.
To me, the bigger problem with coming to the hospital is having a fall at home, which is a big, big issue with sarcopenia and in coordination that these patients have.
So a question for both of you, and very controversial, is after a patient recovers from an episode of overt HE, what are your instructions regarding driving?
3 months. Overt HE, the consensus now, which has been published, is no driving for 3 months.
And do you reassess them after 3 months?
After 3 months is where the white knuckling period for recurrence goes away.
Mm.
And for minimal or covert HE, there is absolute no restriction at all. So it's only for patient being confused. 3 months, within 3 months after that episode. And after 3 months is up to the patients have to really, let me put it this way. We are not policemen.
Yeah.
We have to tell them, document them, make sure that their caregivers know, because this is a tremendously increased burden for the family.
Yeah.
If one of those people cannot drive and now someone has to ship them around.
Yeah.
So you want to document all of that. Most of the time, the caregivers have seen the patient be absolutely confused in the hospital. Either, they brought them in that way, or, they know how bad things are. So I've almost never found an issue where patients and their family members have said, no, I will still want to continue driving. If you want to continue drive, the patient insists, then you have to write a form that is specific to each state. As you know, states' rights and all that. You want to make sure what your laws are in your state, whether you are anonymized, whether you can actually put that together. So that clearance then shifts the onus of considering fitness to drive to the DMV for your state. All you can do is advise them that this person should not drive.
Right.
For that patient to win their right back, they have to go to the DMV. There's nothing that you can do and put a magic wand as now it's 3 months.
Yeah.
You're done. Once they're medically unfit for driving, they have to now prove it to the agency.
Okay. Vargas, your approach? for
I've
driving?
always used the data that I've read on Bajaj's work to do this. And I usually advise my patients who have had hepatic encephalopathy to avoid driving at night. If they're going to drive to areas that they're very familiar during the daytime. And the only things that I've done formally to try to limit somebody's ability to do something is I've called the FAA on 2 patients who had pilot licenses that did not want to give up.
Wow.
I did not want them flying over me with hepatic encephalopathy. And I think that's a federal agency, not a state agency. So the FAA probably wants to know about this.
Oh, yeah.
Worst are the school bus drivers. That's the worst. So it's horrifying.
Yeah.
It's horrifying.
That's
You don't want to ask. You almost don't want to ask what you do for a living at some point.
There's a question in the back and we'll go to the front. Dr. Scheinbaum?
Yes, for Hugo, could you comment on the use of fractional excretion formula for diagnosing, evaluating patients with
Good question.
HRS?
Good question. Repeat the question.
Fractional excretion formula.
FENA.
Um,
You use it at all, Hugo?
I don't use it, so I don't know that I have much to comment on that.
No. Dr. Kinley,
Okay.
question in front.
I just like to share my experience. I was involved as an expert witness for a colleague who examined a patient in Hartford, Connecticut, and diagnosed that the lady had early encephalopathy. Didn't say a word to her. She went into the parking lot, reversed a 350 Mercedes into a person behind, and broke both their legs. And he was now being sued by the person who had leg broken because he did not tell her not to drive a car. So be very cautious if you have anybody who's encephalopathic to allow them to drive. I think you guys are being a little optimistic. I'd be very nervous. I'm actually an examiner for pilots at the Aviation Medical Examiner, and they cannot fly again once they've been encephalopathic.
Oh, no.
They can fly as passengers, but it's not as pilots.
Oh, we received another question about albumin fusion. And we all understand that after 5 liters of fluid removed, which give albumin, but you have people with borderline kidney function, small stature. I mean, should we be more aggressive albumin in these patients to prevent, hemodynamic complications or HRS?
Unfortunately, albumin is expensive. The question is really whether do you use albumin in patients who have lower volume paracentesis. I think you know your patients very well, and I think that that battle has to be fought on a one-by-one basis, because I think sometimes insurance will limit what you can do with patients. But I don't remember I've been denied aggressive albumin replacement recently, no matter what the actual volumes are. And we have a protocol that essentially lists it out very carefully, and the radiologist triggered that. If they get 1 liter out, I don't think that's really important. I've also had some insight. I'm participating in the Alpha Pump study, which is essentially an ongoing, daily paracentesis. And I found that in the majority of patients, we're really limited to 4 liters a day. I don't have anybody that's getting that high a level on a daily basis, but usually 2 liters a day doesn't by day change the creatinine a whole lot. So I've been very, very pleased to see that at least the guidelines that you really need to go beyond 5 liters to begin to replace without really hurting the patient may be correct. And so I think that if you're taking 1 liter or 2 out, you may not really be harming the patient as much as you think you could. But again, the patients that go into this trial don't have renal insufficiency to the degree that it would worry me if it weren't in that circumstance.
Okay, great. Any other questions in the audience before we take a break? So, I'm sorry. Oh, yeah. Yeah, we'll get the microphone. Thank you. They're gonna bring a microphone right now. Thank you. Yes, please.
I have a young man. He's in his 50s, super morbid, obese, heart disease, kidney failure, 1.69 creatinine. He has to go for therapeutic paracentesis every 2 weeks. They get 4 to 5 liters every single time. I'm scratching my head. I can't give him too much more in diuretics. I'm just not sure where to go with it. Do I send him to hepatology? GI does pretty much as wash their hands of him. Any suggestions?
Oh, okay. Has the patient been seen by a liver transplant unit and told he's not a transplant candidate?
No, you have not.
Okay, I think that would be step number 1. I would continue doing planned large volume paracentesis like you have. You've already optimized diuretics as much as you can. So this patient is a decompensated cirrhotic patient who needs to be seen by a liver unit. If they deem him not to be a candidate, I think that there are options if you wanted to consider where the patient is and how they're doing, the level of encephalopathy. TIPS could be an option. Oh, he's got heart failure. Okay, sorry, I didn't hear that part. So I think that continued large volume paracentesis until you know that he's not a candidate for transplant is the way to go.
All right. Thank you. But at this time we'll start. Oh, one more question? No. All right, we'll stop for a break. Reconvene again 9:30. We have a number of exciting lectures. First one will be state-of-the-art lecture on liver transplantation by Michael Charlton. We'll see you back at 9:30, everybody. Thank you. Thank you, speakers. And we have a very exciting second half of this morning's session. We will have our four speakers, a question answer. And we've just announced that we're going to have a very nice, thorough, and elegant summary with Dr. Steve Flam before finishing off with UNOSI. So let me see the first slide. There it is. So it gives me great pleasure to introduce a very dear friend and colleague who will be speaking today on the state-of-the-art lecture on liver transplantation in the United States. Dr. Charlton is a current professor of medicine, director, Center for Liver Diseases, and director of Transplantation Institute at the University of Chicago. So without further ado, Dr. Michael Charlton.
Thank you, Sam. I'd also like to thank the organizers and Zubair in particular. Really, the idea that, think about a year ago, and here we are having to wear sun lotion at a conference. We're in person. It's really tremendous. So thank you, and thank you to CLDF. But very few things have changed as much as liver transplantation has in recent years. It's a pleasure to be able to review some of those for you here today. I have disclosed, but not relevant to my presentation today, as I'm really not describing any drug use. There are maybe no major parts of medicine that have a greater debt to a single individual than liver transplantation does to Professor Thomas Starzl. And while he was at Northwestern, he really signaled to the world that he was intending to perform liver transplantation when he published this paper in 1960, where he had performed en bloc transplantation in 19 dogs, essentially taking the liver, spleen, pancreas, and intestine with some success. Not only was he at the forefront for this idea, he was already using machine perfusion. So here's one of his dog livers getting hyperbaric oxygen and machine perfusion in the 1960s. So really a forward thinker, something which is now back at the fore today. Now, 1963, having already seen a somewhat successful, but not very successful transplantation for heart and for kidney, Dr. Starzl presented or published his first paper in liver transplantation in humans. There were 5 recipients. The first child was a patient with biliary atresia. The first adult was an African-American man with alcoholic cirrhosis. None of the first 5 survived even 23 days. And most of the deaths occurred very close to the time of transplantation. It was obvious from the beginning of Starzl's work that he intended for this to be something that was disseminated. It's a very instructive paper that he published. And one of the most interesting aspects of the paper is where it was published. It was published in Surgery, Gynecological Obstetrics. Now, this is one of the most impactful papers in modern medicine. And here it is. Any of us which has ever had a paper rejected from our journal of first choice, which is anyone who's ever had a paper published, you can still get wonderful results and have a huge impact if you publish in somewhere other than your first choice, if the information is important. But again, it was like a manual of how to do this procedure. Here he is with vena bypass and showing even the suture technique and the anastomotic techniques. The results were bad enough that people who were also carrying them out shortly after Starzl had in Paris, Boston, and in London, everyone agreed to stop doing it. Nobody was living long. It clearly wasn't a life-saving procedure in these patients. In 1967, the first patient to survive a year was recorded, and it's Rebecca Rodriguez, shown on the knee here. She had biliary atresia. There was a painting that Dr. Starzl had commissioned of Rebecca Rodriguez, really in honor of her suffering and the spirit of her and her parents in going through this. And this is something which endures to this day, the bond that we develop with our patients, the trust they place in us, and the hope for an extension or a second phase of life. He had this painting near his desk until the day that he died not very long ago. In 1983, the Surgeon General for the United States, C. Everett Koop, I believe his name was, said that it was now a clinical service, that liver transplantation was something that they considered of clinical utility. And the group from Pittsburgh at the time, Dr. Starzl, Jake Demetrius, who was a pathologist, David Van Thiel, the hepatologist, who really was the father of transplant hepatology, put together this position paper. And it's an interesting read to this day. They point out that the conceptual appeal of liver transplantation is so great that the procedure may come to mind as the last resort for virtually every patient with lethal hepatic disease. They were totally correct. They projected that you could need as many as 4,000 up to 50,000 per year if supply was unconstrained. Those projections turned out to be exactly correct. Interestingly, they also published the fees, the professional fees associated with the procedure, and the surgeons get around 20 times as much for the 5 to 10 hours work as a hepatologist for their years and months of work. That ratio persists to this day also. Even in the 80s, outcomes were better than they were, but they weren't wonderful. This shows two things that I extracted from SRTR's archives, looking at 3-year patient survival and the frequency of steroid-resistant rejection. And you can see they almost exactly mirror each other in an inverse way. 1970s, we had cyclosporin being this addition to azathioprine and corticosteroids. The 1990s, tacrolimus, and subsequently mTOR inhibition with sirolimus and everolimus. We've certainly tamed rejection as a cause of graft loss. Did it very well. Out before and after the advent of direct-acting antivirals. Sofosbuvir was the first to be approved in 2015. So we consider after 2015 to be there. And you'll see on the dotted lines at the base, this is hepatitis C positive transplantation graft survival, and the pre-era and the post-era is in the solid lines above. So this delta, this gap has now been totally bridged. Some of the best results now are obtained in patients with hepatitis C. So enter the World Health Organization somewhere in Zurich. I visited 12 countries in the Far East and the Pacific when I was president of ILTS. And I never saw a member of the World Health Organization. I saw the CHI, which is the Health Access Initiative, and many other groups. I never saw the World Health Organization members, but they did come up with these projections, which were 90% reduction in new chronic hep C infections, treatment of 80% of eligible persons, and a 65% reduction in mortality rates. This is downloaded from their website. So how have we done with these wonderful drugs that you can cure everyone with 8 to 12 weeks of therapy, one pill once a day in many instances? So there's around 70 million people who have hepatitis C infection globally. The number that have been diagnosed is probably around 12 to 13 million, so a tiny portion of that. And the number that have been treated globally is around 2 million. And this is despite, if you are in, say, Myanmar or the Philippines right now, the cost of an entire course of antiviral therapy, somewhere between $250 and $500. So it's not as low as the $1 to $2 a day or for the course that Dr. Alter has hoped for, but still it's adjusted for GDP and per capita income and some access initiatives that the pharmaceutical industry has enabled, but still very low penetrance. And I can tell you, having been to places in the Philippines, Indonesia, Myanmar, there aren't healthcare providers of any kind in large swathes of these countries. So absent a vaccine, there is no possibility of any of these targets being reached. I would say zero possibility. It's almost silly. But we have seen a rise in hepatitis C RNA positive donor organs. So as a society, we struggle with many things. The opioid epidemic is one of them. This looks at the number of reported cases of hepatitis C, and in its heyday in the 1960s, there were around 135, 150,000 new cases per year. Thanks to the opioid epidemic, we're now close to 50,000 new cases per year. So we're in the midst of a new epidemic of new hepatitis C infections. Although we have these wonderful drugs, not only are we not decreasing, we're seeing an increase in new infection rates. Coupled with this, in just a 5-year period, we have witnessed a 10-fold increase in deaths related to opioid overdoses. And many of these are occurring in young people, and it's an anoxic head injury. Patients who die from this are often excellent potential organ donors, and many have, in some cases, more than 10% of people who die related to opioid overdoses have hepatitis C infection at the time of their demise. In 2015, we performed the first knowing liver transplantation of a patient, of a donor who had hepatitis C, RNA positivity into a patient who had PSC and who had no history of hepatitis C. There's a computer programmer who had recurrent cholangitis, and at that time did not believe that we would not be able to treat his hepatitis C post-transplant. There's now been a 35-fold increase in liver transplantation of hepatitis C positive organs. I think many centers, probably the great majority of centers now, would routinely accept a hepatitis C positive organ for hepatitis C negative recipient. This was almost unthinkable before 2015. So this is one of the most dramatic changes. And the outcomes were projected to be good, but how good are they? Well, the first thing is that the age of the donors is, as you would project, is low. The age is lower than you see for hepatitis C negative donors in the SRTR. And the BMI is lower as well. These tend to be thinner recipients, or donors, beg your pardon, and fewer of them are donation after cardiac death, because most of the deaths relate to this anoxic brain injury. And the outcomes are inseparable from patients who undergo liver transplantation with hepatitis C negative donor organs. So now I think what was hypothetical a few years ago is now absolutely confirmed. This is an excellent source of donor organs. The first patient that we did a liver transplant in with hepatitis C positive donor into a negative recipient was over 1,000 down on the wait list. It was turned down for 1,000 recipients ahead of him. I think now you're lucky to get less than 50. Now, for years, the most common cause of death in patients with HIV was hepatitis C-related liver disease. The ability to suppress HIV was excellent with highly active antiretroviral therapies. And there was this window before we had direct-acting antiviral therapies for hepatitis C. And in that window, the most common cause of death for HIV, patients living with HIV, was hepatitis C-related complications. In 2013, the HOPE Act was initiated or approved by Congress. This was really put forward by Johns Hopkins and Doris Segev, and this permitted the transplantation of organs from HIV-positive donors into HIV-positive recipients. At the time that this act was put into place, though, outcomes were very poor, about 50–60% survival for liver transplantation recipients co-infected with HIV and hepatitis C. So it was very a brave act. There were more recent data from Europe and the United States reporting through 2015, but not beyond, that HIV-infected liver transplant recipient outcomes had improved in the DAA era, but with really a very brief window to look at it. But the HCV co-infection continued to take a toll and attenuate outcomes. So we recently looked at the current status of liver transplantation in patients with HIV and hepatitis C. Now, the first thing is the frequency has been greatly increased with the advent of direct-acting antivirals, and the frequency of HIV positive and Hep C positive shown in the lower part of this graphic. And on the right-hand side of this is someone that we lost in 2020. This is Larry Kramer. He is a playwright, author, and an HIV activist. He was the founder of ACT UP, and without question, and as acknowledged by the FDA and by Anthony Fauci himself, he accelerated through his pressure and activism the development of heart therapies and for access to liver transplantation. He very publicly underwent liver transplantation for his diseases at the hands of the wonderful surgeon, Dr. John Fung. And Larry Kramer passed away just a few months ago. But there has been a dramatic increase in liver transplantation for HIV. The outcomes have really not been reported in the DAA era to this point. And what we're seeing is there's been a shift from 58% 3-year survival to exactly the same survival, 82% 3-year survival for people with HIV, Hep C, co-infection in the direct-acting antiviral era. So there's no longer even a relative contraindication or any trade-off in outcomes for patients with HIV. And this is a dramatic turn of events. Multi-organ failure is another change in liver transplantation landscape. So there are between 70 to 80,000 people living with Fontane's procedure in the United States alone. And the cornerstone of the Fontan procedure is that the venous return from the cava goes directly into the pulmonary arterial supply. And the engine for the Fontan procedure is high venous pressure. And this pressure will typically run not less than 10, it really couldn't flow with less than 10, into 20 plus. And this presents a functional chronic outflow obstruction to the liver for these 70 to 80,000 patients living with Fontan's procedure. And it's a multi-stage procedure, recently changed from 5 steps or 3 steps to 3. It does come at a cost. You get this chronic outflow obstruction, venous hypertension and congestion. You get fibrosis versus congestive heart failure. It's very hard to distinguish the two. You get this nodular regenerative hyperplasia, and some of the most dramatic nodules you'll see on cross-sectional imaging of the liver will occur in patients with outflow obstruction following a Fontan's procedure. The Fontan's typically fails after 30 to 40 years, and now we have this cohort of patients that are aging to the point they're in their 30s and 40s, presenting with heart failure and liver failure related to the Fontan procedure, 70 to 80,000 of them. So the challenges are when to refer. The great majority of cardiac surgeons, I'm going to estimate 9 in 10 out of cardiothoracic surgeons are not able to operate on a multiply cardiotomized chest. So once somebody's had 3, 4, 5 cardiotomies post-Fontan's, that chest is often frozen and very hard to get out of. So when to refer patients so that they can even be considered for a heart transplantation with or without liver is one of the primary questions regarding congenital heart disease, multi-organ failure. Very complex surgery, and I would stress the great majority of cardiac surgeons will step away from these procedures. There has been, as you may have predicted from the demographics, a logarithmic increase in heart liver transplantation in the United States. So for the congenital heart disease shown in the dark bars in this graphic, you can see this tremendous increase, but still only 21 in 2019. We performed a third of those at the University of Chicago. We're blessed to have Val Jeevanandam, who was a once-in-a-generation heart surgeon. It is very patchy in terms of the availability of the performance of this procedure from one region of the country to another. You see it more in the Southwest than you do in the Northwest, for example. And this probably represents or reflects differences in capabilities. These are 4 of the 20 people in the world who have ever undergone triple organ transplantation, heart, liver, and kidney. The surgeon in the middle is Professor Yolanda Becker, who happened to go for her lunch, and she saw these 4 patients. She put the kidney into all of them having lunch together, and they had found each other and connected. But interestingly, these 4 were 4 of the 20 in the whole world. About a month ago, we had 5 patients evaluated in the same week. So we're beginning to see this uptick in referrals for multi-organ transplantation. I project that every center in the United States will start to see more and more of these patients. The outcomes are actually pretty good. So the bottom 2 lines are for congenital heart disease. There is definitely a trade-off in early outcomes. The lines separate early and they stay separated. And it may reflect the highly transfused rate. So there's a high level of patient reactive antibody in patients who undergo congenital heart disease related to heart transplantation and liver transplantation. But once you get beyond the first year or so, the lines are pretty proximal to each other and certainly acceptable outcomes compared to ischemic cardiomyopathies and non-congenital heart disease transplant patients. One of the interesting observations that was made in this analysis is that practice doesn't make perfect, but it makes you a lot better than without practice. If you are a lower volume center, and lower volume just means less than 1 per year, 1 or less per year on average, you have about 5 times the graft loss rates than if you do more than 1 per year on average. So this is probably not something that every center should do or probably has the capability to do, but they certainly need to think about how they will refer and manage patients with congenital heart disease related multi-organ failure. So the average rate, again, if you're greater than 1 versus less than 1, dramatically different. So the remaining question, how to assess these patients, is interesting. When we looked at our entire experience, the best histology was in the patient with the worst cross-sectional imaging appearance. And the worst histology we saw in somebody with the best appearing cross-sectional imaging. This NRH that you get, which is diffuse in patients with congenital heart disease and associated liver failure, leads to a very difficult to interpret set of pictures. It's also easy to miss HCC because of the venous outflow. The scan sequences for triphasic CT and for MR protocols needs to be adjusted to reflect differences in blood flow. So it's easy to miss HCC in these patients also. The reversibility of the liver disease is an important question. So if you have somebody with, say, stage 3 disease, can you do the transplant? Should you? If you have, say, a completely compensated Child's A, what about them? Will it reverse if you do the transplant? Nobody actually knows the answer to these questions, of course. But interestingly, in SRTR, 3 of the deaths, remember there are only 21 cases in a year, related to liver failure following a heart transplantation for Fontan's or congenital heart disease. So it's something which is an emerging era of interest to the field. And 2019, UNOS changed its allocation policy to one which I think is already having an impact on decreasing regional variation in accessibility to organs. Does anyone know what the largest liver transplant program in the country is right now? It's right here in Phoenix. Dr. Hugo Vargas is the director of this. So Mayo, Arizona has now the largest liver transplant program in the country. Probably would not have seen it without this organ allocation change as well. There's been a profound effect on many aspects of transplantation, one of which is waitlist mortality overall is declining quickly. But in addition, there's this National Liver Review Board. So all of the variation in getting a successful appeal for chronic encephalopathy or resistant ascites, that's all gone. It's very hard to get those successfully appealed now. And HCC has been de-emphasized as an indication for liver transplantation. And this means there's a substantial increase in wait times for patients with HCC. So you see the number of deceased donors has increased in concert with anoxic brain injury among opioid overdose patients. But living donor frequency didn't appear to have increased substantially, despite, in theory, an important increase in need for living donor transplantation. Now, waitlist mortality and dropouts are very important to consider together. Usually what you hear is waitlist mortality. But if you look a little bit more closely at the data, the pre-transplant mortality rate is around 12% nationally, down from about 18% before these allocation changes favored people with very high acuity, MELD scores 35 plus. But there's a 37% waitlist dropout rate, 18% dying or being too sick for transplant, 12% other, no good reason among the others. And only 7% are improved and transplant no longer needed. So the likely toll on the waitlist is probably closer to 30% than it is to 10%. And this looks at the number of causes or the relative reason to be taken off a waitlist. So on the left is waitlist mortality, but on the right, liver transplantation as a cause to come off the waitlist is the yellow. And you see the second most common to come off the list is removed because you're too sick. So there's a substantial potential need. This is Alyssa Smith. She was the first living donor recipient in the world. Interestingly, both the first recipient of any transplantation and the first living donor recipient both had biliary atresia. She underwent liver transplantation at the hands of Christoph Brosch, also died within the last 18 months. This was performed at University of Chicago. She's still alive. This is a picture of her graduating high school. So wonderful procedure for those that undergo it. And sure enough, there has been a dramatic increase in liver transplantation using a living donor procedure. On the left is total living donor transplantation in the United States. And interestingly, the Asan Medical Center in the Republic of Korea performs more living donor liver transplantations than the entire United States in a single year. They have multiple donors for the same recipient. They do all sorts of interesting things. They'll have 10 surgeons performing that procedure when that is performed, by the way. So overall, it's increased by 33% since organ allocation changed. 28% for decompensated cirrhosis, but 45% for HCC. And I think we're just beginning to see this uptick in living donor transplantation for liver cancer. but it's very unequal. This looks at the geographic variation in liver transplantation, which is performed with living donation. And you see almost none of it where organ access is high and much more of it where organ access is lower. Now, this is the Good Samaritan attending the traveler who was attacked and left for dead at the side of the road. He had been passed by two clergy members, and the Good Samaritan, a total stranger, came to the victim's aid. The number of Good Samaritan living donors where it's a stranger donating to somebody that may be seen on Facebook or some other mechanism of identifying the patient has increased dramatically. In Pittsburgh, they do nearly 100. They're on course to do 100 living donor procedures. Almost all of them are with Good Samaritan donors. It's more than the rest of the country combined. Outcomes for living donor are often thought to be as good as they are for deceased donor. It's not true. Patients pay a price in terms of graft survival. Graft survival is unquestionably lower if you have a living donor procedure. It's exactly what you would expect. There are technical aspects, and all of the increase in graft loss occurs early in the postoperative period. The center volume affects outcomes. Now, one of the canards in liver transplantation, you cannot get to a living donor talk without hearing about if the center has done 20, patients do fine. So that this minimum 20 threshold from Kim Althoff's work at the living donor or A2all NIH study. And it's certainly true, but is there a frequency effect? And this looks at the effect of frequency. It's the paper now in press. And if you have less than 5 in the last 2 years, you have about 4 times the likelihood of graft loss than if you have greater than 5. And if you do more than 25 in the last 2-year period, your outcomes are really excellent, shown in the top line. So there's a dose effect of not just total experience, but of frequency. So there is a learning threshold, but there's also a frequency effect. Now, back to Bacchus. The second part, of course, was alcohol. And you can see alcohol shown in the middle here, increasing dramatically as an indication. Now, the pandemic has been good for mostly no one. And this was a study out of USC and Brian Kim looking at the sales of alcohol in the United States before and after or during the pandemic. And there's been a 32% increase in alcohol sales. That sounds about right to me. The adjustment, if you account for the fact that restaurants are closed, people have to buy the alcohol to consume at home, it's still somewhere between a 12 to 20% increase. So not surprisingly, we're seeing an increase in deaths. And this is CDC data for alcohol mortality in the United States. Alcohol is the top line. NASH, by the way, is the second from the bottom here. So the NASH epidemic, it's there, but it's not far off hepatitis B, according to the CDC, as a cause of cirrhosis-related mortality relatively recently. And this looks at where the burden is being borne, and it's young people. So people who are 25 to 34 have the greatest rate of increase in alcohol use disorder, alcohol-related liver disease, and cirrhosis overall. So we're starting to see all of us are young people with acute ALK-HEP in our transplant centers. This is Philippe Mathurin's paper where they randomly assign patients to get liver transplantation or standard of care. And you will not see a medical intervention with a greater survival benefit than liver transplantation with alcoholic hepatitis. And there's certainly no other medical procedure that we withhold on the basis of patient contribution to their disease to the degree that we do for liver transplantation. It's a 48% delta. This is the difference in frequency of liver transplantation before and after Philippe Mathurin's paper. So alcohol on the left, you see the great increase. And on the far right, there's hepatitis C with NASH also increasing, but still on the heels of alcohol. If you look at the proportional increase, alcoholic liver disease and acute alcoholic hepatitis, shown on the far left, is by far the quickest increasing indication for liver transplantation. But again, highly variable. So these are the frequency within the UNOS region. So the average is somewhere between 1% and 2%, but some regions over 4%. So that must be because some regions have a higher burden of alcoholic liver disease. Let's have a look, see if that is true. So the highest frequency is in the Northeast, places like New York, for liver transplantation for alcoholic liver disease, but it's actually the lowest incidence of disease. So these are the CDC data for the intensity of binge drinking in the US. So the practice varies in dissociation from the burden of disease felt nationally. So some sort of standardization for these patients is needed. But encouragingly, this is a paper looking at outcomes. The big concern is, does drinking cost the liver? And the answer is no. The best outcomes in the country right now are obtained for transplantation for acute alcoholic hepatitis. There is not even the beginnings of a trade-off for recurrence of disease at either 1 or 3 years. And finally, the rise of the machines. The big thing in liver transplantation now is machine perfusion. There was a paper in New England Journal just a couple of weeks ago showing this machine, which is a hypothermic, so a cool device, about 10 degrees centigrade. And really it's an oxygen delivery system. University of Wisconsin, an HTK solution, provide all sorts of things like antioxidants, et cetera. But they really didn't deliver oxygen. So machine perfusion is a way of resuscitating an ischemic organ. 156 patients randomly assigned to this device or not. And this is specifically in DCD organs, and about a quarter of the frequency of ischemic type biliary strictures in people who were randomly assigned to receive machine perfusion. This is going to totally change organ transplantation. So now this is the question for, does it improve stricture formation in DCDs? The answer is yes, it does. But now the question is, well, can we take organs that are being thrown away? So fatty livers, organs that are slow to go down following DCDs, et cetera. These questions are going to be something that you'll see at meetings for the next 5 or 10 years. This story is just beginning to unfold, and centers will start to have to get access to this technology. And the very last thing is, go back one if I can. This is sofosbuvir, and this is the NS5B of Hep C, and for the polymerase for SARS. Yellow is for SARS, blue is for hepatitis C, and they almost totally overlap. And sofosbuvir has good activity for other flaviviridae, West Nile virus, dengue, Zika, et cetera. There's a group from Iran, 3 studies showing a survival benefit with sofosbuvir. We're just beginning a multi-center study for sofosbuvir for post-transplant SARS-CoV-2 and COVID disease. On that note, I conclude. I thank you very much for your attention.
So that was indeed a state-of-the-art lecture. Thank you, Michael. The next speaker, Dr. Coley, we're talking about autopsy of pediatric liver disease. This is particularly important to adult hepatologists, where we're seeing a large number of young patients maturing and aging, and we need to participate as caregivers and takers for these patients. Dr. Coley?
Thank you so very much. The last day of the conference is always hard to get through, but hang in there. Thank you to the organizers, Dr. Saab and Dr. Zanosi, for inviting me. These are some of my disclosures, well, hopefully all of my disclosures. Just leave them up for a second. I will be talking about 2 or 3 new agents that are in the pipeline at the very end, and I'll point them out at that time. So what are we interested in when you talk about pediatrics? And then, as you very nicely mentioned, Dr. Saab, going into adults, what are the outcomes? I think we're always interested in survival. Very nice talk preceding me, state-of-the-art lecture. I was very happy to hear biliary atresia. I was very happy to hear congenital heart disease, music to my ears. But we're still interested in quality, right? Survival is important, but quality is also important. What are we doing to our children, to our young adults? And then what's beyond transplant? Can we avoid transplantation? Nothing against Dr. Starzl, Professor Starzl, amazing lineage that he has set forth, and for us to propagate and help children and adults. But there are things now that we need to think about, whether it is the right decision to transplant someone or not. And I'll highlight some new therapies there. So awareness, there's a long laundry list of indications for pediatric liver transplant. As a pediatric hepatologist, and there's a few of us in the room here today, well, outdoors, here today, that can attest to this, that we're always asked this question: do children get liver disease? Unfortunately, the answer has become yes, and also more. These used to be the indications for transplant. I'm not going to go over them, biliary atresia being the top number. But when we start to think about screening for these disorders, we have to go to the general practitioner. I, as a hepatologist sitting in an ivory tower at the Keck School of Medicine in LA, can't screen for pediatric liver disease. For biliary atresia, we have to talk about the surgeons who are doing Kasai hepatoportal enterostomies. Are they reestablishing bile flow? If they do it on time, it's successful 70% of the time. It prolongs the life of the native liver, prevents liver transplantation for years. But if you do it a little bit too delayed, there's only a month between 60 and 90 days, if I calculate correctly, and the outcome of interest drops from 70% to 25% or less. So it's a precipitous drop because biliary atresia is a progressive cholangiopathy, worse than PSC, faster moving than any of those two. So time is bile. Nothing against Tina Turner, but time is bile. So what do we screen with? So if you are a general practitioner in the audience today, please look at the top 3 colors. I know they're not projecting very well. Hopefully there'll be handouts, but those are clay or lightly colored stools. The bottom 3 are normal pigment stools. So as a gastroenterologist practicing in pediatrics, I've gotten used to saying there's only 3 bad colors in poop, mom or dad. It's either red, of course, if you see blood, it's black if you see old blood, or it's the absence of color or pale stool. Any other shade of green, blue, pink, orange, I'm all fine with. So these cards have been in use. This is from a publication by Lee et al. A few years ago now, but have been in use in Taiwan, in British Columbia, and many other areas across the world to tack down the delay that we have in screening for biliary atresia. And these are very simple. If the parent sees, and there's actually now an app, there's always an app nowadays. There's an app for this too. It's called Poop MD. If you want to look in your app store by Doug Mogul from Johns Hopkins. And you can take a picture with that app and they'll tell you if your stools are acholic or colic. The American Academy of Pediatrics has taken this on, and I'd like to urge you to proselytize this. Dr. Casper Wong from our group was the lead author on this, and saying use stool color cards to try to see if we can make the presentation of the child less delayed from 90 to 60. So only a 30-day change and can only be identified in the primary care office. What can we do in the hospital setting? This is going into our neonatology and newborn nurseries. If we do a fractionated bilirubin, it's a small step. We all think about, as pediatricians, at least in the nursery, about physiological jaundice. If you go back to your medical school days, if you're not practicing pediatrics, it's the most common jaundice form, right? Physiological jaundice. However, we only follow the nomograms with total bilirubin. Nothing against the nomogram developer. It was life-changing for children, prevents kernicterus, but does not pick up on biliary atresia. If you just once fractionate your bilirubin, it's $4 more. It's worth spending because, as shown by this paper in pediatrics from Texas Children's, the differentiation is stark. You can pick up children on day of life 1 if they have elevated direct bilirubin. So when you get the bilirubin, just fractionate it. So these 2 messages for screening, I would like to leave you guys with. So talking about the medium-term survival, right? So if you pick up the disease, and you have to go to transplant, very nicely put together the overall concept, but I'm just showcasing our center really quickly. We've done about 406 of pediatric liver transplants since '98, of which 134 are living donor. And I think I emphasize that because living donor for children is really responsible for bringing down the mortality on the wait list, because you don't need the whole liver. Typically a relative, mother or father, can donate, and it does make an impact on survival. 97% these days for 3-year survival for children, at least at our center. And you see these smiling faces at the end of it, and they grow up to be medical students and have children and be pediatric hepatologists. Like one person is trained here in Phoenix and went now to Cincinnati. So I think the long-term survival has gotten better and better. These 2 pictures showcase, again, I'm sorry if there's a bright screen, but the top picture is from 1998. The baby in arms had a liver transplant. The bottom picture is 2016. The same child is now standing on the extreme left of the screen. She is now a fully grown individual. And the child in the middle is the next generation of living donor recipients. This is amazing. And there's a picture of the 2 of them together, 20 years apart, living donors. So cured? we have medium-term survival if we screen appropriately and we can showcase a few anecdotal beautiful victories? No, not really, right? So because we have, as highlighted, other epidemics right behind us. We have NAFLD, we have NASH, and it's happening in children. Again, now we not only have to deal with the litany of congenital disorders like biliary atresia, but NASH in pediatrics is a real thing. This is data recently published by the UCSD group in collaboration with Kaiser Permanente of Southern California, where the NAFLD incidence has doubled almost over, you're going from 36 to 58.2 per 100,000 in the Kaiser Permanente system in Southern California. New England Journal of Medicine showcased a few years ago by Tom Inge and the group from Colorado and Denver, in adolescents, we're doing bariatric surgery. Pediatric bariatrics has increased to almost 1,600 cases a year in the United States today. So not only are we seeing old disorders, which we still need to screen for and proselytize for, but now obesity, NASH, and bariatric surgery in children. What is next? So no, we haven't, I think Dr. El-Khoury is still in the audience, unless he left because he thought I was going to speak. But his paper back in 2017 highlighted that this then slips over into the adult side, that the fastest growing reason for transplants, and you know when it's in the Washington Post, it's real, right? The New England Journal, you don't know, but Washington Post for sure. But long story short, we still have a disease to deal with, even if you transplant these young adults who have NASH. As you look at Merriam-Webster or your favorite dictionary, Cambridge from the UK, a disease is something that is a problem that you have to take a medication for, in my mind. And transplantation, despite the amazing outcomes, 97% survival at 3 years and all the options we have today, still needs care, still needs daily medication. So it is a disease. So you're not really curing a problem, you're exchanging. I tell this to all of our transplant eval patients that I have to be transparent with you. If we are successful in getting you across the bridge of transplant, you are now exchanging your problems. You're not curing your disease. So if one must take a pill, I think it's still a disease. So we talked about survival. Yes, we can get to survival, but we still get to survival with a disease. What about quality? How is the quality of life? And Dr. Estelle Alonso from Northwestern has done a ton of work on this. So some of the work will be from her group. We can see this is from Vicky Ng from Toronto Sick Kids in collaboration with the SPLIT, which is the Society for Pediatric Liver Transplant recipients. They showed that if you look at, I'm just going to highlight one thing over here. If you look at a cohort of, and this was a large cohort, the SPLIT cohort is one of the largest pediatric liver transplant cohorts in the world. If you look at them at 10 years out, of course, they're 80% alive, but are they alive and doing quote unquote ideally? Are they only taking one immunosuppression? Have they not had chronic rejection? Do they not have PTLD? Only 1 in 3 have ideal survival. So the quality of life issue is important. If 2/3 of our patients either are on multiple drugs or develop diabetes or post-transplant metabolic syndrome, so on and so forth, I don't think we've done all right by them as best as we can. So there's room to improve. So behind the curtain, you have chronic allograft injury. Of course, there's many things going on immunologically that we don't understand yet completely. So the work has to go on. And again, I apologize. What I'm trying to show is that there's interface activity at the level of histology. You can see that in surveillance biopsies in these individuals 5 years out. So pre-diabetes, I just talked about 40% at 5 years post-transplant. And then of course, insulin resistance because of tacrolimus. Our calcineurin inhibitors inherently will cause more diabetology. So we're making friends in endocrine. So the point being, if you have all these problems, like now, of course, we as hepatologists starting to talk about donor-specific antigen antibody as well as DSA type rejection, and that we never thought about before, but now we're having to face with these class 2, 41% positivity. So if you have DSA positivity, you have 3 to 4 grade fibrosis. A lot of this work is coming out of UCLA. So the point is to get to, the reason I put up this slide is it's a very complex environment where you have family, child, puberty, medications, and all the immunology that goes along with that. To get from stem to stern, and Dr. Gonzalez is in the audience. He can attest to this, developing the program in Florida. To get from stem to stern in a pediatric program, you probably need more resources than you do in an adult program. And don't hit me with a badger head afterwards, but I think so. That's I think there's much more. I'll give you an example. One of our patients, when I was back in Cincinnati, transitioned to the adult program at university. And they complained that an email came back after the first visit on the adult side. There's no pizza here. So I think we do a lot of hand holding on the pediatric side, and there has to be a hand off when we transition these patients to the adult side, a lot more involved. So briefly talk about what the challenges kind of, if I were to highlight three, I like threes for some reason. So biomarkers, we still need definitely more reliable diagnostic testing. Treatments, are there ways that we can take a step away from CNIs? I know we love CNIs. Are there ways to be either better at the therapeutic or decrease the, like we've gone away from steroid usage? Are there other drugs in the pipeline? And then long-term outcomes, of course. So biomarkers, we're just highlighting one where we're working on with Juliet Imamali at Keck, and she's looking at CyTOF, at single cell CyTOF to see if we can replace biopsies. This is a paper under review, so I won't go too much in detail about it. So let's go into the final part of the talk, which is beyond transplant. We talked about how we can maybe have good survival, but we still have a lot of work to do with quality of life after transplant. But are there things that we should be thinking about even before signing off on listing the child? So this is a beautiful picture I keep using over and over from Professor Ott's group back in the 1990s, where you're seeing a child getting a piece of the liver and reliving life, so to speak, the gift of life. When is transplant, though, not the correct option is the question I'm trying to ask here. So if we talk about beyond transplant, neonatal hemochromatosis, Dr. Peter Whittington was one of my mentors, mentors are for life. So is one of my mentors back at Northwestern, and high dose IVIG, he showed that if you have a mom who is having repeated episodes of first or second trimester losses, and you suspect due to histology and so forth, investigations on the autopsy from the dead fetus, that this is neonatal hemochromatosis. The next time around when they get pregnant, you can prevent neonatal hemochromatosis. This was a paper in Lancet now almost 2 decades ago. So we should be thinking about that. Dr. Liz Rand from Children's Hospital of Philadelphia then went on that, what about the children that are born with neonatal hemochromatosis? Can we give IVIG to them postnatally? And she showed an improvement as well. So definitely there are pearls in NH where you can do it either for the mother to prevent first trimester, second trimester losses, or in the newborn to save their lives. This is a potpourri of acronyms. If you are not a pediatric hepatologist, please bear with me, but this is a congenital defect called PFIC, or progressive familial intrahepatic cholestasis type 1. Say that 4 times really fast. We used to do surgical biliary diversions for this, and they were good, but what they didn't convert was, of course, prevent transplant long-term. I'll showcase a drug in a few slides that talks about how we can avoid it. Bile acid synthetic defects, where you have children with cholestasis who do not have the appropriate technology in their livers to produce bile acids. It was a very common misconception early on that you can't do anything about it. Then doctors Jim Hybe, Balistreri, and Ken Setchell produced cholic acid. Well, they didn't produce it, but they put it together in their lab and they gave it to children and bypassed the abnormal pathways, overwhelming it by providing exogenous cholic acid. And you can cure these children. You don't need, you can see the C and D compare, of course, pre and post cholic acid therapy, fibrosis by a serious red stain. So if you can identify disorders that have treatments, that's the theme that I'm trying to convey. Alagille syndrome, one of the conundrums that we've always faced is you have a lot of angiogenesis defects. So you have PPS, peripheral pulmonic stenosis, and of course you have cholestasis in these children. We looked in the research sphere a lot about intrahepatic circulation, and we do understand that the ileum, depending on which side of the pond you're from, is where bile acids get reabsorbed. And pharma came to the rescue. Now we have ASBT or IBAT, whichever acronym you like, bile acid reuptake inhibitors that are in the pipeline. There was a recent study on Alagille syndrome that got published, and it shows that you can reduce serum circulating bile acids, decrease pruritus, decrease xanthomas. And maybe those are the reasons you were doing transplant in the first place for children with Alagille syndrome. So right now, this is pending FDA approval, so it's not out there yet. So this is one of the drugs that I was going to talk about, but they have given in February breakthrough therapy designation to this drug. I promised you I'd come back to PFICs. What about trials of the same drugs in PFIC? So they've had IBAT inhibitors being tested in PFIC types 1, 2, 3, and 4. I won't belabor the genetic defects, but they're two different companies, and I'm not going to proselytize on any one of them, but they are working towards using these in PFIC disorders. Again, PFICs were some of the congenital disorders we were transplanting children for. Maybe we don't need to do them now because of all these studies, FIC1, FIC2, and Indigo, that have just recently been published. These are all trials going on with IBAT inhibitors, which are in the pipeline or just finished. Gene therapy, we used to talk about it as if it's Space Odyssey 2020, but wait, it's 2021. So the real piece of evidence is that most of us probably got the mRNA vaccine. We're already actively using gene therapy in one sense of the word. So what about for these congenital disorders that are genetic defects? So there are, again, not prime time yet, but definitely looking towards integration, especially for all these PFICs. So both IBAT inhibitors and gene therapy are in the pipeline for PFICs. Last but not least, Wilson disease. A lot of adult practitioners know about Wilson's disease, and now we have bischoline tetrathiamolybdate that is in the pipeline. The study has been concluded, and we're going to see the pediatric study data hopefully soon as well. And what they're watching for is non-ceruloplasmin bound copper, and whether or not that is the right outcome measure. Again, we can debate that, but that is what they're watching for. And I'm really looking forward to seeing what the data are in totality when it comes out. But the trial has definitely finished completion in terms of recruitment. So now we look forward to the data. So to summarize the three phases that we talked about, survival, I think if we continue to identify new targets in rejection, we can promote and prolong survival by preventing rejection. Quality of life, especially for children, we do feel has been shown to be inhibited by transplant. Even though you survive, you do need to have a better outcome in terms of quality. And then beyond transplant, I will continue to say that we need to keep looking for not going into the disease, but curing the disease you have. Thank you so much.
So wonderful talk, and I think it highlights the need for an increasing partnership between pediatric and adult liver transplant, liver hepatology patients. So next talk is by Dr. Reddy, very instrumental in the careers and academic positions of many faculty. He's got an incredible reputation. He is Founders Distinguished Professor of Medicine, Professor of Medicine and Surgery, Director of Hepatology, Medical Liver Transplantation, University of Pennsylvania. And he's going to give a really timely talk on the interaction between COVID virus, COVID practice, and managing liver disease in today's environment. There you go. Dr. Reddy. Thank you, Raj.
Sammy, thanks so much for this nice introduction. And I want to take this opportunity to thank CLDF for putting this meeting together. It's really been wonderful, and it's really given everyone an opportunity to get together. I think it's important for our sanity, so at least my sanity, to get out. So yesterday, you heard a great enlightening talk by Harvey Alter talking about the steps one has to take towards success. And it's really quite a wonderful, humbling talk. So, well, when I look at my journey with COVID-19, it began last year. I think I'm still at the first step. And I guess, given my activity in this area, I've been invited to give a talk. So I must say I'm no expert on this, but I'll do the best I can. So it was quite fortuitous, interestingly. A year ago, Bob Fontana from Michigan just sent out an email to all those who are part of this acute liver failure study group, asking questions as to how they would handle this COVID situation with regard to patients with liver disease. And then Ray Chung, who was on the email as part of AASLD, suddenly decided to get a group of people together to try and address this issue. And then there have been several publications on behalf of AASLD on these topics. And I'll try and update you on where we stand with some of the recommendations. So these are my disclosures. Nothing would be relevant to COVID talk. As an outline, I will talk about AASLD expert panel consensus document on hepatology practice, while address outcomes in patients with advanced liver disease and COVID-19. Also talk about outcomes in liver transplant recipients and they have COVID-19. Talk a little bit about the trends in liver transplantation during COVID-19, and lastly, touch upon vaccination in patients with advanced liver disease and liver transplantation. So this is an overview of hepatic issues or observations in those who have COVID-19. To set the stage, the functional receptor for SARS-CoV-2 is the angiotensin converting enzyme 2-ACE2. It's present in biliary and liver epithelial cells, so there is reason to believe that there might be a direct infection of the liver by SARS-CoV-2. Now, there have been innumerable reports out there on abnormalities in hepatic biochemical tests seen in the context of COVID-19. It's ranged anywhere from 14 to 53%, primarily subtle elevations in ALT, AST. Bilirubin elevation has been reported in the more advanced cases of COVID-19, and low albumin has been noted to predict severe COVID-19. Now, what is interesting is that there have been rare cases of severe acute hepatitis described, and actually this comes from David Bernstein's group. And it's interesting, you don't see acute liver failure, isolated acute liver failure due to SARS-CoV-2. So whether this virus is capable of causing severe isolated acute hepatitis remains in question. Now, when you see abnormalities in hepatic biochemical tests in these patients, could be due to any number of reasons. It could be a manifestation of multi-organ dysfunction. The variety of drugs that are used in treating COVID-19, potentially they could be responsible for drug hepatotoxicity. It might be inflammatory or immune response. Is it a direct viral effect is the question, and really this is unsettled at this stage. And it could be other factors as well, such as perhaps hepatitis B reactivation, etc. Now, the provocative paper that suggests that this might be a direct pathogen comes from China. To a large extent, hepatic abnormalities are felt to be an innocent bystander situation, but is there a direct hepatic pathogen? So there are over 150 cases of COVID-19, and so a good number had some abnormalities in hepatic biochemical tests. And then they had 2 cases of autopsy liver biopsies, and they looked at them very carefully, and they demonstrated apoptosis and binucleated hepatocytes, suggesting that there was injury to the liver. And then using the Tunnell staining, they've also demonstrated apoptosis. And last but not least, an ultrastructural examination, they showed viral spike structures that they thought resembled SARS-CoV-2. And then they also demonstrated some mitochondrial proliferation and endoplasmic reticulum proliferation, suggesting that this virus can cause direct liver injury. This has really been a provocative paper. Now, in the context of hepatitis B and C, there might be some unique considerations that you would need to keep in mind. Most importantly is the potential for reactivation of hepatitis B, because there are certain therapies that are used in treating this infection that potentially could reactivate hepatitis B. Tocilizumab is one, prednisone is another that have traditionally been known to cause reactivation of hepatitis B. Now, with regard to treatment, treatment of hepatitis C, if it's been started prior to COVID-19, there's no need to interrupt treatment. Similarly, there's no need to interrupt hepatitis B treatment. If they're on it, if you want to initiate for a newly diagnosed hepatitis C or B therapy, it all depends on the resources you have to treat those infections. Now, there is no consensus based on the data as to what the outcomes might be in patients with advanced hepatitis B and C when they have COVID-19. I think my sense is that the outcomes are dependent on severity of disease and not specifically to the infection. So if they have cirrhosis, they're likely to have adverse outcomes. Now, histologically, if you look at autopsy series, there have been a couple of autopsy series that have been published. This is one from Italy. Most often, they've reported steatosis. And then, of course, interestingly, and not surprisingly, in some cases, they have noted thrombi in the sinusoids, and you know, these patients have a thromboembolic phenomenon elsewhere, so it's not surprising that they had a thrombi in the sinusoids when they examined liver wedge biopsies from autopsy cases. Now, there is this expert panel consensus document that AASLD has developed. It's online. It was first started in March of last year, and it's been updated several times. There's a link that you have here that can get you to the document. It's I believe, one of the more commonly downloaded AASLD documents. It's been translated into Spanish and Portuguese. The manuscript has been published way back right after the first version of the document was released. And what was suggested in the document is that if you had abnormal hepatic biochemical tests in the context of COVID-19, you kind of rule out the rudimentary common causes for abnormalities, while hepatitis B, C, look for drug, and then follow the patient. And if, of course, the abnormalities resolve, you know, that's the end of the story, but they do not resolve. Still, this stage, we really do not have a good sense of what a liver biopsy might achieve in these patients. So it's generally, you see progressive abnormalities in hepatic biochemical tests, and particularly severe abnormalities. It's often in a severe COVID case where the outcome is likely to be poor. And the consensus is that a biopsy is not going to help these patients. Now, whether one would want to move them to do an ultrasound to rule out vascular abnormalities such as thrombosed portal vein, thrombosed hepatic artery, is something that you'd have to consider. If you could do it one at the bedside, that would be a better way of doing that study. Now, with regard to autoimmune hepatitis, one key thing is initially there was a sense that perhaps we should taper down immunosuppression preemptively, but the consensus was that one should not make any anticipatory adjustments to current immunosuppressive drugs or dosages if they do not have COVID-19. But if they do have COVID-19, it's probably reasonable to decrease immunosuppression, but we have to understand that it's potential flare with such a strategy. Now, antimetabolites been out in the news, so to speak, and particularly in the context of liver transplantation, and I'll address that a little later. So there is a tendency to drop azathioprine or CellCept, but generally the studies have shown that there is really no greater risk of poor outcome while they have COVID-19, while they also have antimetabolites on board. Now, alcohol-associated hepatitis, what do? You know, we see a lot of alcohol-associated hepatitis come into the hospital, and they do have COVID-19. Should you use, or is it reasonable, or is it safe to use prednisone or prednisolone or other immunosuppressive therapy? You know, obviously, you have to look at the potential benefit versus risk. It's a individual, subjective position, and one cannot really provide any solid guidance. Now, management of hepatocellular carcinoma, when the document came out, we suggested that those who are in treatment pursued HCC treatment, surveillance was recommended. Perhaps a delay of 2 months was reasonable. However, what one has noticed, at least I have anecdotally, is that patients have skipped surveillance for a long time, and they've now come with large untreatable cancers. And it's rather sad because not uncommonly at our multidisciplinary conference, the tumor conference, cases are presented where patients at risk have gone without surveillance for over a year and now have large tumors. So we really should be on top of it and encourage our patients to have their surveillance. A little bit of delay, a window is okay, but not a long delay such as for a year. Liver transplantation. Initially, obviously, liver transplant volumes went down, and the volumes varied across the country because certain centers, they had high COVID-19 cases. I was talking to Bob Brown yesterday, and he said that during the peak of the pandemic last year, they only did 2 liver transplants because their ICUs, their operating rooms were all occupied by COVID-19 patients, and there were only 2 cases of acute liver failure that transplanted. But some other centers, transplant volumes were reasonable, and it's now, I'll demonstrate that they seem like they are back on track to pre-pandemic days. Now, what are the outcomes in patients with advanced liver disease and COVID-19? There are any number of papers out there, but I'll point out to 2 papers. One is from Italy, where they noted a 30-day mortality of 34% in patients with cirrhosis who had COVID-19. And then if you look at a breakdown and compared to those who just had cirrhosis and infections, the COVID-19 patients had respiratory failure, and that they had a higher mortality relative to those who had cirrhosis and had bacterial infections. Now, this is a nice study that Jaz Bajaj put together from 7 sites looking at outcomes in patients with cirrhosis who had COVID-19 and those, of course, who did not have COVID-19. It's a nice contemporaneous cohort study with good matched cases. There were 556 patients with cirrhosis admitted to 7 sites during the study period. Of those 556, there were 37 patients who had COVID-19. And then at the same time, there were about 1,380 COVID-19 cases without cirrhosis. They were matched 1 to 2 to 1 to 5 by age and gender by each site. So eventually ended up with 37 COVID-19 cirrhosis patients, 127 cirrhosis without COVID, and 108 COVID-19 positive patients without cirrhosis. And what was noted was that those who had cirrhosis and had COVID-19, they had a higher mortality than COVID-19 alone. But then the mortality was similar to those with cirrhosis only without COVID-19. So what was noted here was those who had COVID-19 in the background of cirrhosis and died, they died of COVID-19 complications, whereas those who had cirrhosis alone without COVID-19 died of cirrhosis-related complications, variceal hemorrhage, et cetera. So it's an interesting study. Cirrhotics had a higher mortality compared to COVID alone without cirrhosis. Now, what about outcomes in liver transplant recipients? They had COVID-19. Initially, particularly from New York, there were reports of high mortality in these patients with COVID-19. And there are all kinds of perturbations in terms of decreasing immunosuppression, et cetera. But the nicer study, which I really like, is this one from 2 registries. The registries are Secure Cirrhosis in the US and COVID HEP registry from the UK. And these collaborators have done a terrific job. In fact, they've published quite a bit on COVID-19 in liver disease and liver transplantation. So what they did was they looked at all liver transplant patients who had COVID-19 were hospitalized. And then from Oxford Hospitals and National Health Trust, they identified patients who had COVID-19 but had not undergone liver transplant. They did a contemporaneous cohort study. And they demonstrated that basically those who had liver transplant had COVID-19, they had a higher rate of ICU admission, higher rate of invasive ventilation, but more importantly, mortality was similar. It was same. What increased mortality was age and comorbidities such as increased creatinine and non-liver cancer. So the point here is that just because they had a liver transplant, one should not assume that they're going to have a higher mortality rate relative to anyone else who develops COVID-19. And here, you see overall mortality was 28% in the liver transplant recipients versus 27% in the comparison cohort, and was similar. Now, are there any chronic consequences of COVID-19? And I'm not sure at this stage, but I want to point out to this one entity and one paper that again has come from New York, from David Bernstein's group. They report on 3 patients, ages 25 to 40, all on mechanical ventilation, all on vasopressor support, all had acute injury, and 2 of 3 had biventricular systolic heart failure. So they had hemodynamic compromise of a major degree. And then they looked at their pattern of liver tests. The top 2 panels represent ALT and AST. The bottom panels represent alkaline phosphatase and bilirubin. There's 3 patients, and you can see that their ALT, AST settled down early on, but subsequently they had alkaline phosphatase and bilirubin elevation that was prolonged. And then on MRI, they described cholangiographic abnormalities mimicking sclerosing cholangitis, and talked about a cholangiopathy related to COVID-19. Histology, they demonstrated ductular proliferation, cholangiocyte hypertrophy, and then they also had some bridging fibrosis And then they also noted features of sinusoidal obstruction syndrome. So they is suggesting that perhaps SARS-CoV-2 can cause chronic disease, particularly in the form of cholangiopathy. Remember, I said these patients had major hemodynamic compromise, and one thought is whether these represent cases of ischemic cholangiopathy rather than a direct SARS-CoV-2 infection-related chronic disease. Now, trends in liver transplantation during COVID-19. During the early part of the pandemic, there was a decrease in live donor liver transplantation and also a decrease in cadaveric transplantations, but more so of living donor liver transplantations. And then it really has picked up, and we're back to the pre-pandemic state. And it's not only observed in the US, it was observed in the UK as well. And then there are also a decrease in cirrhosis hospitalizations in the VA system, as demonstrated by my colleague Nadeem Mahmood. You can look at the top one, blue line is the pre-pandemic cirrhosis hospitalization rate, and the red line is the post-pandemic cirrhosis hospitalization rate. But I think they're picked back up and almost close to the pre-pandemic state. Now, lastly, I want to touch upon vaccination in the context of advanced liver disease. Again, AASLD has developed a document on it. As most of it is based on what we believe in, not necessarily based on solid data. It is recommended that these patients with advanced liver disease or chronic liver disease, for that matter, any stage of chronic liver disease, be prioritized for COVID-19 vaccination. Just to kind of let you all know, if you look at the large clinical trials that have been done, there have been less than 200 patients in either of the two major earlier vaccine studies. Less than 200 patients with chronic liver disease who have been in these trials. Yet, recommendations are out there that they should be vaccinated. It said there's a favorable efficacy and safety profile. Again, this is based on less than 200 patients in each of these clinical trials. Patients who are receiving antiviral therapy for Hep B or Hep C or medical therapy for primary biliary cholangitis, et cetera, can be vaccinated. And that the medications need not be withheld while they're being vaccinated. Carcinoma patients, HCC patients should be vaccinated as well. And if they had recent infections or fevers, it's best not to give COVID-19 vaccine. Or SARS-CoV-2 vaccine, I should say. There is lack of data regarding safety and efficacy in immunocompromised patients and transplant patients, although there's some data that's evolved in transplant patients that I'll talk about. It's felt that there would not be a safety concern since there's no live or attenuated virus that would be given for all solid organ transplant recipients. And then it's recommended that you wait at least 3 months post-liver transplant to administer the vaccine, although there is actually now a push to vaccinate all those who are on the waiting list. And then if they have acute cellular rejection, it's best to avoid vaccination in these liver transplant recipients. So as of today, what is it that we know, and what are the unmet needs with regard to vaccination? What we know is that we have vaccines available, that at least in the general population, they're safe. In the liver transplant recipients, it has been shown to be safe. There's actually a nice data that has come out from Johns Hopkins in liver transplant recipients where they've demonstrated safety. Now, the efficacy part is the one that has really caused some angst. The Johns Hopkins group published a paper in JAMA where they had 436 transplant recipients who were vaccinated, And the antibody response to the spike protein was 17%. And this has really caused a lot of angst among liver transplant recipients. And on top of that, the recent, safety concern raised with the vaccine has been another reason that people are not too eager to take the vaccine. Sort of interesting. Apparently, the complication rate of this thromboembolic phenomenon is about twice the risk of lightning hitting someone. Yet it's really caused quite a bit of angst. So there are huge unmet needs with regard to vaccination in these patients. We have patients like, for instance, hepatitis B and C are relatively more common in Black Americans. What is the vaccine response in those people? Non-alcoholic fatty liver disease, you see more often in Hispanics. What are the vaccination response rates there? So there's a lot of work that needs to be done when it comes to vaccination. So finally, my take-home points, you can see a wide range of the reasons for hepatic abnormalities following SARS-CoV-2 infection. High mortality has been observed in patients with cirrhosis, both with COVID-19 and, of course, contemporaneously admitted cirrhotics without COVID-19 had high mortality. Different reasons for mortality. Those with COVID-19 died of COVID-19 complications. Cirrhotics without the infection died of cirrhosis-related complications. Now, liver transplant recipients initially were thought to be vulnerable to this infection, but subsequent studies show that they have the same outcome as those who did not undergo liver transplantation. Transplant rates have picked up and seem like they're at a pre-pandemic state now. We do have best clinical practice document from AASLD. There's a separate document on vaccination that is going to be periodically updated. You can easily access those documents if you had any questions. And vaccination, every day there's something out there. While we start off with a great deal of enthusiasm, lately there has been some dampening observations that have put a damper on our enthusiasm, particularly patients' enthusiasm. But I think we really should encourage our patients to get vaccinated. I'll stop here, and thanks very much for your attention.
Thank Raj for an exciting talk on COVID-19 and liver disease, which has impacted all our lives and our patients' lives. The next speaker is Dr. Laura Kolek, Professor of Medicine and Surgery and Intervention Radiology. Wow, that's a new one. From Northwestern University, Chicago. She's going to talk on a very complicated topic of liver cancer. Liver cancer has become a specialty of its own the past several years. After Dr. Kolek's talk, we'll have a question and answer, and then an exciting summary by Dr. Steve Flam. Laura.
Thank you for the invitation. I'd like to congratulate the organization for taking on this first in-person meeting. It's been great for everybody. I think everyone is happier, and the enthusiasm, you can just feel it. Raj, I know you're much happier now that we are here in person. So these are my disclosures. So from a historical perspective, I wanted to show the birth of the BCLC staging, which was in 1999. And you can see it's pretty backbone minimal. It has different stages. There were a total of 4 at that point in time. And the point was to pair the stages with the recommended treatments based on the results of randomized controlled trials, which in 1999 was quite sparse. And this is just to highlight what's going on now. You can see that it's much busier of a slide. Your attention is drawn to the advanced patients who there is now a litany of medications that have been approved, which I'll show you later. Also, the thing that is happening is this stage migration, particularly in people with TACE. Instead of going to TACE, which has been the backbone in intermediate cancer, there has now been a push to go to systemic therapy earlier so that patients are not too decompensated. from being overtaste and then lose their opportunity for systemic therapy. But I put in, this is the downstaging. This is not part of this, but I think we need to keep in mind that there are people who will stage, migrate, or transition the other way, where they had advanced disease, and you may be able to treat them. And I'll talk about that later in the talk. At the bottom is all the ongoing trials. So you can see that there are trials going on involving immunotherapy in the earlier stage. So people have been resected, as well as patients intermediate and continued therapies in the advanced, which are mostly combination therapies. So I think that one of the most important points is that now that we have all these different therapies, it's really going to prove to be very important that we work in a multidisciplinary fashion. It's been shown in multiple publications that the more we work together with other disciplines, there is a better improvement in patients' overall survival. So these are what everybody accepts as the potential curative options in HCC: ablation, resection, or liver transplantation. I have highlighted some of the considerations or possible contraindications to each of these therapies, but I do want to point out that liver transplantation still provides the best overall survival with the least chance of recurrence in patients who are carefully selected, which currently is the Milan criteria, but we're going to talk a little bit about selecting patients outside of that criteria. So within the last 3 weeks, the FDA approved the use of glass microspheres for radioembolization for the treatment of HCC. Before that, it was on a humanitarian device exemption. And this was based on the Legacy trial. This was a multi-center retrospective trial of 162 patients. And the primary endpoint was overall response rate, which was met at 88%, and with a duration of response that was long. The patients were included if they had only one lesion up to 8 centimeters. However, the median tumor size was only 2.7 centimeters. Most patients were BCLC-A, so early, and patients were included in the C category based on performance status, not based on metastatic disease or having portal vein invasion. And the overall survival in the 45 patients who subsequently went on to a surgical option, transplant or resection, is shown here at 93%. So very, very encouraging. So this is now approved for patients with HCC. So I'm going to talk about what we've been doing with radioembolization, particularly in patients who are not candidates in this slide for RFA, largely due to where it's located. But some transplant centers will not do RFA in potential transplant candidates due to the fear of seeding, although this has been shown to be relatively low, especially with ablation when you are burning the tract. But some of the centers just do not want to do it. This has become another option. This was a retrospective study from Northwestern, Bob Lewandowski, looking at solitary lesions less than 5 centimeters. These patients were not ablatable. They were all Child's PUA, and importantly, none of these patients went on to transplant or resection, so we could really follow their natural history. And what they showed is that when you do this radiation segmentectomy, which is defined by high doses of radiation to 1 to 2 segments, you not only get a good kill in the tumor, but you provide a zone where there is increased chance where the tumor cells may spread, kind of similar to RFA. So when you do an RFA, it's always a larger zone. And similarly, we're seeing this. And they found that the 5-year overall survival in patients who had a lesion less than 3 centimeters was 75%, which is right in line with what we consider other therapies that are considered curative. So what they concluded is that this provides a response rate in tumor control and survival outcomes that are similar to what we have accepted as potential cures. So will people start to use this as a potential cure? We definitely have been doing this in patients who are not transplant candidates or older patients as a destination therapy. But there are other forms of radiation. Some centers are not allowed to use Y90 or don't have the expertise, so they're using SBRT. This is a trial that is ongoing in Indiana. It's looking at a single lesion in patients with liver function that's preserved, and they have to have had no prior local regional therapy. And interestingly, this is a feasibility study, so it's a total of 20 patients. So to see if they can go on to do a larger study to really look at there's a difference between radiation segmentectomy and SBRT. Because SBRT is being used in many centers. I've highlighted this. Most of these are retrospective, and the control rate within the tumor was similar in most of these studies compared to SBRT. Interestingly, in Toronto, they use SBRT as a form of bridging bridging therapy, and it is used when patients are considered too sick to get TACE therapy. And when they looked at this, even though these patients were more ill from a liver standpoint, their ability to get to transplant and their overall recurrence rates were similar. So SBRT is being used in other centers, and they're also using it in patients with advanced disease in combination with TACE, which was found to be superior in a randomized control trial compared to sorafenib. So there are patients who are considered resection candidates based on that they have good liver function, but the problem is that their future liver remnant will be too small. And generally it's accepted that you should have a 40% FLR for patients who have underlying cirrhosis who are undergoing resection. And this was a serendipitous discovery that they found when they were doing total lobes radiation, that in patients that they couldn't do a transplant, so they decided to do the entire lobe, they found that the other side of the liver was growing. And this was found as early as 1 month, and this continues with time with an increased median of 45% by 9 months. And this has subsequently been shown by other centers. So we are now using this as a way to get people to resection who are otherwise good candidates, but we're worried that they don't have enough future liver remnant. So this has opened doors for patients to get a potential curative option. There's more research that needs to be done on this. This is a small study of 25 patients who underwent radiation lobectomy and subsequently had a resection. And the patients who had the total lobe radiated had a much increase in their future liver remnant compared to those who had segmentectomy. That makes sense. And the recurrence rates were higher in patients who did not have a response radiographically prior to resection, and in those who did not have more than 50% necrosis. The problem with this is these were all patients who had already been resected. So we don't know what is the total number of patients who you intend to resect who won't make it to resection. So there is an R01 that Bob Lewandowski at Northwestern is specifically trying to tackle this question. So in the West, we generally will comply with the Barcelona criteria for resection, which is a single lesion, regardless of size, in child Q8 patients with no evidence of clinically significant portal hypertension, either by the HVPG of being less than 10 or surrogate markers, what I've listed there. And also the bilirubin less than 1 and an HVPG less than 10 has been shown to be the best predictor of overall survival. However, there have been challenges to this. There was a bridge study, which was retrospective in over 8,000 patients, and they found that only 60% do they follow these recommendations. And interesting, they found that if your bilirubin is above 1, you may do okay. If you have some portal hypertension, you may do okay. But if you have the combination of both of those are patients who do very poorly. So it should not be attempted. What about resecting patients in Child's QB? It's an interesting question because why are you not considering transplant in someone who has a Child's QB state? This was a retrospective trial from 14 centers, and the numbers were small, probably for the very reason that I just said. And what they found is that if you could do minimally invasive surgery, so laparoscopic, and a minor resection, which is 3 or less segments, then those patients had a significantly improved mortality as well as morbidity. And so they came to the conclusion that liver resection could be performed in very carefully selected Child's QB patients, and came up with this nomogram that one could use in terms of predicting their overall survival as well as their risk of recurrence. So moving on to transplant, we really need to look at transplant and what is the gain in life in patients when you transplant them. So if someone has a HCC that is outside the Milan criteria, you are running the risk of recurrence and death post-transplant, so you will decrease their transplant life expectancy. If someone has a very low risk of dropout on the wait list, which has been well defined as a small lesion with a low AFP, Child's PUA, and a MELD less than 15, as well as response to therapy, then the life that they're gaining is very minimal, and those organs should be going to someone else. So I'm going to concentrate on the left here on the patients who are higher risk. And there are many different models that have come about in terms of trying to prognosticate beyond the Milan criteria. The Metro ticket, I think, is being used the most. So it's kind of when you're on a train, the further you go on the train, the higher the price you're going to pay for that ride, the higher the price of potential recurrence may occur. So they've come up with this number of up to 7. So it is the largest lesion plus the sum of the lesion. So if you have a 6 centimeter lesion and it's solitary, 6 plus 1 is 7, and so forth. They have gone beyond this and incorporated the AFP. So if you have up to 7 tumor burden, your AFP should be less than 20. The more your AFP is elevated, then the less tumor burden you're allowed in order to achieve a 5 and 10-year overall survival that is acceptable. And they have a app that you can go on that you can look at the size, the number, and the AFP, and it will give you what your HCC specific 5-year overall survival is predicted to be. And this has been helpful to, and for this trial, which I was really surprised that they were able to do this. This was a randomized controlled trial and people with intermittent HCC performed in Italy, where they take patients and they did their treatment. And then once they used this calculator after the response to treatment, and they found that they were going to have at least a predicted 50% 5-year survival, they then randomized them to transplant versus no treatment. This would never be able to be done in the United States, but they did have, it was a small trial. But not surprisingly, the patients who received transplant, their 5-year overall survival was 77% compared to those who received no transplant, which was 33%. And I think it just hammers home the point that transplant is the best treatment for HCC, as well as validates the work that's been done by UCSF that downstaging can be done. This has also been done in a multi-center trial for living donor. And I think we need to start being more aggressive with patients and downstaging them and getting them to transplant. Now, switching to intermediate, TACE has been the backbone of therapy in intermediate cancers, and we've had this definition of TACE refractoriness. So if you've treated the same tumor twice and you do not see at least a partial response, or your AFP is going up, it's time to abandon that therapy. But before, we didn't have anything to go to. Now we have a litany of medications to use. So instead of trying TACE, they're now redefining what is unsuitable. So who are patients who you shouldn't even try to do chemoembolization on, and you should go to systemic therapy. So you jump over to the advanced treatments. And what they have found is conditions that are likely going to become refractory, they're using up to 7, where you're likely to deteriorate the liver by using TACE and then not have them be able to get their systemic therapy, again, is up to 7 and an LV grade 2. And then other conditions that are unlikely to respond, mainly massive tumors or those that are infiltrated. So using this definition, and if you look in the yellow and in the pink, those are patients who are beyond the up to 7. This is a retrospective study by Professor Kudo, where he looked at patients who were either received lenvatinib because they followed this pathway of not going down chemoembolization, versus those who got chemoembolization and looked at their outcome. And of note, if you got lenvatinib, they still had patients who still had some tumor that may not have responded, that they then did chemoembolization. And what they found in overall survival as well as PFS was significantly improved in patients who were put in the early systemic therapy as opposed to going to chemoembolization. So I can tell you this is being pushed very hard by many different institutions and places that you go, because we have all these medications and we want to give patients a chance to get these medications, because here I've listed first line, second line, and ones that were approved by the FDA and accelerated approval. And on the bottom, all these were limited to Child-Pugh A patients. So if you're doing TACE or radioembolization on patients who are intermediate and you keep doing it, then the fear is that they will eventually become Child-Pugh B, and then your ability to use these medications becomes limited. In the real world, we do know that people do use medications in Child-Pugh B. They've done this of sorafenib, and they've actually had a trial in nivolumab in Child-Pugh B. So there is some limited data. This is a busy slide. I just want to point out in terms of some of the medications that cabozantinib is the only tyrosine kinase that has been found to have potential role in third-line therapy, and that atezo-bev is now the standard of care. In terms of immunotherapy, monotherapy with PD-1, most of the nivolumab and pembrolizumab are both PD-1 inhibitors, and they received their approval based on a phase 2 trial just on response rates, which range from 20 to 17%. Based on that, there were 2 randomized controlled trials, both in the first and second line, looking at sorafenib and placebo respectively, and statistically, these were negative trials. But when you talk to the oncologists, they say, but there was clinical meaningful survival improvement of 3 to 2.5 months compared to the control arm. So it is in guidelines that there is some consideration for the use of these, even though they were negative trials. But what we're seeing is this combination. So there is biological plausibility of combining HCC. There is a lot of VEGF, which causes immunosuppression. So using a VEGF inhibitor makes sense to apply this with a immunotherapy. And this has been in the LEAP therapy, and then also priming the immune system with a CTL4 and then hitting it with a PD-1 inhibitor or PD-L1 inhibitor, because CTL4 is early on in the immune system, whereas PD-1 is later. And there have been 3 phase 2 trials that have looked at this approach with very encouraging response rates of 22 to almost 19 months. And this has led to ongoing phase 3 trials that we are waiting for the readout. So it really looks like this combination of immunotherapy will be the future. But a little bit about I Am Brave, which was the atezo-bev compared to sorafenib. This was this trial was very surprising. At their first glance of the data, they hit both of their combined endpoints, which was PFS and overall survival, to the point that they couldn't even tell you what the overall survival was when they first approved it in atezo-bev. 12 months later, and recently presented at ASCO, we now know that the overall survival in that combination is 19.2 months compared to 13.4. and as well as improvement in PFS. So this has now become the standard of care in patients when you're treating with in patients with either from BCLC-B or patients with advanced disease. But what are the things as a hepatologist and gastroenterologist that we need to worry about? When there were earlier trials with just BEV, there were up to 20% rates of variceal bleeding. And so everybody in this trial 6 months prior had to undergo an endoscopy. And if they had untreated or not completely treated varices, they were excluded. So when you look at the number of patients, there was about a quarter in each arm. These were all Child-Pugh A patients, a little bit lower than what you may expect for patients with cirrhosis. And less than 10% of them had received any therapy. But it's becoming very unclear what to do with these patients because they didn't say how they treated them. Was it a beta blocker? Did they ban them? How long did they wait? We don't have that information. And many people are worried that a beta blocker, the reason they bleed is not necessarily due to portal hypertension, but it's at a local level as a result of the anti-angiogenesis. So using the Baveno criteria is probably not something that I think we can do in these patients, and all these patients, in my opinion, should undergo an endoscopy prior to starting this medication. And then also hepatitis is more common in patients who are treated with IOs when they have underlying liver disease compared to all the other cancers. And when you combine those IOs, it becomes even as high as 20%. And this is a very nice algorithm that was put together by Bruno Sangro, taking into account that we do have patients at the baseline before they even get therapy that they have increased enzymes. So they have these grades, and patients, when they're already starting higher, you may be taking them off therapy because they have underlying liver disease. And it's really important to make sure you rule out other kind of medications or hep C or drinking that could be leading to them going off of medications inappropriately or starting them on steroids, because it's been shown that use of steroids probably leads to lower response rates, as well as antibiotics and PPIs, which was recently published. So this is data from HCC TAG. This is courtesy of Dr. Al-Kahuri. This is, I think, a very nice breakdown of the approach in advanced HCC with the medications that we have. If you are Child-Pugh A and no contraindications to bevacizumab or IO, that would be the treatment. If you're Child-Pugh A, but there are contraindications, they have severe autoimmune disease, you would be sorafenib or lenvatinib. If you're Child-Pugh A, but there's a concern for bleeding or wound healing, then sorafenib or lenvatinib, and then this question mark of nivolumab, even though this was a negative study. And then if you're Child-Pugh B or have a poor performance status, there is data of use of sorafenib and nivolumab, although in the nivolumab trial was only up to Child-Pugh B8, and you could not have had encephalopathy or ascites within 6 months. But again, as a transplant hepatologist, I think we have to have a cautionary note that if we start treating patients too early because we have these drugs, what if they could be downstage? And what is the implication of giving these drugs in patients who could have been downstage? There are a lot of questions that we don't know. If they respond to immunotherapy, can you transplant them? How long do you have to wait and take the drug? The drug has a half-life of about 26 days. Do you wait 3 months, 6 months to make sure that the tumor is not progressing? How long do you wait until the drug is out of their system? And then what do you do with them post-transplant? This was a report that was in 2019 of a patient who, I won't go through all the iteration, but over 2 years he was treated and he was on nivolumab for about a year and had remarkable response and was re-evaluated at the transplant clinic, who decided to transplant him. And his last dose of nivolumab was 8 days prior to transplant. And shortly thereafter his transplant, he started to have a significant increase in enzymes, was treated with immunosuppression for rejection, and unfortunately died shortly after transplant. The explant showed no evidence of disease. And on the right-hand side there was PD-1 staining that they did in the liver before they put it into him, which shows none of those brown spots. And then on a post-transplant, when he was having severe increase in enzyme, you can see that there's PD-1 all over, indicating that the drug that was still in his system is attacking the new liver. So a lot of concern on how to use these medications. Also at TAG, there was a presentation from Mount Sinai, where they have used this approach of using PD-1. I don't think their intent was to bridge to transplant, but they called it bridge to transplant. I think they had patients who were put on and had remarkable responses, and they reevaluated them for transplant. And most of these patients, 8 out of 9, had received their transplant within a month of their last dose. So the medication was still in them. And when you read the article, they hypothesized that their median packed red blood cells was 7 units, and perhaps the drug was washed out by the over transfusion that they received, but not enough that you can indicate to give people blood during the time of transfusion. But they had much better results, and they had one patient who had a rejection that was very easily managed, and no patients have had recurrence or have had evidence of severe rejection or graft loss. And when this was presented at HCC TAG, the PERS author said that their approach is now going to be waiting at least 3 to maybe even 6 months. So even though these 9 patients were transplanted within a month, they're going to be changing that. So this is just showing you the trend. We know that the natural history of HCC is to go to progression and that patients die of this. However, there are patients who, what I call stage transition, even from the advanced stage. And this is what I'd like to talk about. So there has been a retrospective study of patients who had macrovascular invasion. They had no main portal vein, so it was V1, 2, or 3, which is considered an absolute contraindication for transplant. These were patients who had remarkable responses to local regional therapy that included TACE or radioembolization. And their 5-year overall survival is 60%. And the one thing that they found was the most predictive was your AFP at the time of transplant. So if it was less than 10, your rate of recurrence was 11%, which is right in line with what we see with patients with Milan. However, if it was greater than 10, it jumped to 50%. So this is certainly not going to be a lot of patients, but you're going to have to recognize it when you see it and know that this patient may be someone who could get transplanted. In Northwestern, I think we've done about 5 or 6 patients who have been in this situation. I want to talk a little bit about radioembolization. Being from Northwestern, we do this a lot. This has become our mainstay treatment across the BCLC staging system. This was from Mazzaferro and colleagues, where he came up with a prognostic score for patients who specifically have portal vein invasion. It excluded main portal vein and found 3 factors that would predict how that patient would do if you were going to give them radioembolization. Where your portal vein was, so if it was just a branch, considered a segment, how much tumor you had, and what your bilirubin was, and the cutoff was 1.2, and you got points for each of these. So if you had 0 points, your overall survival was 32 months with portal vein invasion, and you were less likely to have evidence of decompensation. If you had over 3 points, then that decreased to 7.8 with a high rate of decompensation. So we have prognostic factors to say who should we consider radioembolization on with portal vein invasion, and who should we say that this is not worth taking this risk and move on to potentially systemic therapy. Now, there have been randomized controlled trials, 2 that were looking at sorafenib versus radioembolization. They used the assumed median overall survival of about 15 months of what we had seen in advanced HCC, and compare this to sorafenib, and how this was a negative trial, did not meet his endpoint. And on the right there, I have multiple reasons or criticisms as to how the trial was designed. with the biggest one being that there was no boosted dose of radiation, which I'm going to talk a little bit about. So it's been found that patients with that you can personalize their treatment and you can improve overall survival, particularly in patients with portal vein invasion. So the dose that you deliver of radiation to the tumor matters. And this is called the threshold tumor dose, which they found to be greater than 205 gray. And when they did this, they found that the overall survival in response was significantly higher compared to those who fell below 205 gray. But it's important safety to say that you cannot do this on everyone. If you give that high of a dose and you are perfusing the rest of the liver with other radiation that exceeds 120 gray, then there is a higher rate of causing decompensation. So unfortunately, this is not something that can be done on all patients. But this was really, I think, very important to improve, to show. This was a randomized controlled trial called the Dosifair trial. This was just recently presented. And what they did is they took patients who were getting radioembolization and randomized them to a personalized approach where they boosted the radiation versus they gave them what they were normally doing when we first started with this, which was just a standard dose. And they followed these patients. And I want to point out that this was a group that had pretty high burden of tumor. You can see there in the pink that the presence of portal vein thrombosis was approximately 3/4, and the size of the lesion was 10 to 11 centimeters, so large tumors. And what they found is in the personalized dose that the overall survival was 26 months compared to 10.7 months. So impressive. And also the patients who received a personalized dose, there was a much higher rate of them going on to a potential curative option of surgery with resection or transplant compared to the standard dose, calling into question the negative results of the trials that I had just shown you. Furthermore, one of the negative trials, which was called SARA, they did a post hoc analysis. It's not only important that you give an increased dose to the tumor, but you have to make sure that that increased dose is going where it's supposed to go. So they can tell people where this is. If it's on the SPECT CT, they know where it's supposed to go, and then you can confirm that on the PET. And the patients who had optimal, they had a significant improvement in overall survival. And they found that radioembolization had a significant improvement over sorafenib. So this trial could have been positive had it been run correctly. But we're not going to do another trial. This is going to be a combination. We're going to use local regional therapy to make cold tumors hot by causing death of the tumor and then having dendritic cells pick this up and then using something like immunotherapy. And this has been shown in one trial that this works. There's something called the abscopal effect. So even if you don't do local regional therapy to a tumor and then you give immunotherapy, you may see death in that tumor as well. And to this end, there are multiple trials that are looking at this, and they're highlighted here. And this is just I thought this was a very, using this combination of nivolumab and radioembolization, this person went on to have a resection and there was complete necrosis and no evidence of recurrence after 6 months. So I really think this is going to be the wave of the future. So in summary, HCC has evolved with several systemic therapies showing improved overall survival. Radioembolization is being used across the BCLC system and is now FDA approved. Combinations of systemics with IO, and VEGF inhibitors plus local regional therapy are being investigated, and the boundaries of resection and transplant are being stretched. Thank you so much for your attention.
If we can invite our speakers come up for a question and answer, and this will be followed by a summary by Dr. Steve Flynn. Thank you so much. So I'll get started with Dr. Cooley. We have a question on what is the overall incidence of biliary atresia in children?
1 in 10 to 15,000. The eastern part of the world, the Japanese population has a higher incidence, but typically 1 to 10 to 15,000.
Thank you. Dr. Charlton, for you, you gave a great talk on using hepatitis C positive grafts with hepatitis C negative patients. What about transplanting hepatitis B source antigen livers to negative
It's a
patients?
good question. The only thing easier than managing hepatitis C in clinic right now is a no-show, I would say. And after that, it would be hepatitis B. You can suppress everyone. I think the guidelines are maybe a step behind what we're able to manage with effective suppressive therapy, whether it's TAF, entecavir, et cetera. I don't remember the last time we lost a liver to recurrence of hep B.
Yeah, I mean, For Dr. Kulik, this is a question more about surveillance. And they're asking that we have clear recommendation for stage 4 cirrhosis. Do we all agree with the benefits of screening patients with stage 3 fibrosis?
So that's a trickier question. EASL has been ahead of SSLD guidelines, and they do screen patients with, initially it was stage 3 fibrosis only in Hep C, and now they've broadened it to stage 3 across all causes of liver disease. Our guidelines have stuck to patients with cirrhosis. It becomes a cost benefit issue. I personally will screen patients with fatty liver disease with an ultrasound once a year, not so much for HCC surveillance, but to know if they are progressing to the point that I need to be screening them, recognizing that ultrasounds in patients who are overweight in men are not as good. And then that gives me a reason to do something like an MRI or CT scan.
Great thing. This is a question from Dr. Ira Jacobson online. Thank you, Dr. Jacobson. He said that he's had a number of cases of COVID cholangiopathy as well. And he's referred several for liver transplantation. He wants to know, have others has had a similar experience of seeing COVID-related cholangiopathy? I know we have at UCLA, and we've had a couple. It's been very difficult. We've also referred one patient for transplantation.
Well, I will admit I have not seen a case at our center, but I've talked to people informally, and apparently there have been cases that have been listed, and one center said the one who was listed died, not prior to transplant, from I guess multiple comorbid conditions. So I do not know of a case that has been transplanted. There might be patients listed. I don't know if, in New York, where there is quite a bit of COVID, if they've transplanted anyone. Bob, have you transplanted anyone with the COVID cholangiopathy? We listed one.
Disease. The patient we listed had like a FEV1 of 1.1, just above our lowest acceptable, and died of pulmonary complications while awaiting transplant.
Yeah, I'm still struggling.
And Raj, if I could say, of the 3 cases that we published, one of the 3 is on the list. Has become cirrhotic, and his lungs are actually fine.
So it's funny how quickly the unthinkable can become routine. There's a now an accepted paper in AJT with a PCR positive COVID patient undergoing successful liver transplantation with post-transplant eradication. It was done at Mayo Clinic in Rochester. The patient had Wilson's disease and COVID, PCR positive pre-transplant, PCR positive post, and then negative. But the key was he didn't have important lung disease at the time. So we need to think differently.
The big question, and again, I'd like to get some opinions, is whether this cholangiopathy is a consequence of COVID infection, or is it an ischemic cholangiopathy? When I looked at those 3 cases, they had profound hemodynamic instability, and I wonder if this was just an ischemic cholangiopathy, or maybe a combination. But then they talk about some changes in liver histology of bile ductal proliferation and cholangiocyte swelling, but that could be reactive too to an ischemic or a cholangiopathy. So
our patient had tons of biliary casts and have multiple RCPs, but still continue biliary problems. Bob, you had a question?
Yeah, real quickly, Dr. Coley highlighted direct bilirubin as an assessment for pediatrics, and are we embracing direct bilirubin now? This for Laura, I think also, and Raj and Michael, in assessing our patients with end-stage liver disease, getting ready for interventions for surgery. Total bilirubin to me is such a distorted number.
So I can tell when we do Y90, and it's the rate at which it's rising, and if they have any kind of shunt, either portosystemic that we did with the TIPS or portal vein thrombosis, that we look and see if it's more indirect versus direct. So yeah, we do use that, the indirect and direct, but also the rise in the bilirubin. Some patients will have cancer and they've had a bilirubin of 3 for a year, and those are patients who are more likely to do therapy. But if their bilirubin was 1 3 weeks ago and now it's 3, on the day that they're about to do it, they will pause.
Yes.
Just
Raj, excellent talk. I enjoyed your, COVID-19 talk. I think, have you guys transplanted anyone who had COVID-19 after certain days? And
So, yes, we have, we are, I guess the guidelines vary from institution to institution. We would want at least 2 COVID PCR tests negative, and then we wait at least 21 days before they're activated. So I'm not sure what policy you might have at your place or.
We
yeah,
have the
at
same one
your
at
place.
UCLA, 2 negative tests in a period of time.
Yeah.
But I called around with other people,
Yeah.
just one, and then they're not waiting.
yeah, anecdotally at Hopkins, we did, so we waited for just like 4 weeks. And the same thing, like the CPU, there is a critical level of viral load above which we don't do that, we wait.
If the lungs look good, why would you worry about the PCR necessarily?
No, apparently that's our ID guys' recommendation was, the critical level of, there's a colony threshold, or,
Yeah, I think this Mayor Rochester case should lead us to rethink.
It's sort of very interesting, where AASLD had a debate on this topic. At that time, the overwhelming majority said we should not transplant. Overwhelming majority, and even acute liver failure, they're hedging. But things have changed. This debate was about 6 months ago. Now you're hearing something different. We're saying, all right, we could transplant these patients pretty early on.
But I think this is why our patients who are listed all should have priority so that they don't get COVID and they're not in
Right.
this predicament, because they have shown in other vaccines that if you vaccinate somebody after transplant, you don't respond as well. I would think there's a better response even with cirrhosis as opposed to post-transplant. But we need advocacy for that.
Well, I just want to, again, clarify this paper from Johns Hopkins in that they looked at antibody response after a median of 20 days after 1 dose. So what might the response be after 2 doses? We don't know. And then, is antibody response the parameter that is necessary to say that they are protected or not protected? That's another question that remains. So, and then I also want to, what it's really also shown is that those who are on mycophenolate or antimetabolites, maybe like this, but mycophenolate and azathioprine, they had a low response. So we're getting a flood of questions from transplant recipients whether they should stop their azathioprine or CellCept. It's really, coordinators are just going crazy about this. So somehow we need to kind of neutralize this sentiment out there among transplant recipients and providers. That is just this one report, one shot. Yeah.
In the last minute, do you guys have a preference for type of COVID vaccine in your liver transplant patients or people with advanced liver disease? A question posed by one of our virtual participants. A choice, whether it be Moderna or Pfizer.
So it's sort of
Johnson?
interesting. If you look at the JAMA paper, the Moderna vaccinees had a higher response compared to the J&J. I didn't want to mention this because it's all about this industry stuff. So I don't know why that would be the case, but that's what they show.
Okay. Well, I think we're going to stop here. Oh, yeah, sorry.
Just one point I wanted to make both on Laura and what Dr. Reddy was saying. Dr. Hulik and Dr. Reddy were saying, kids under 16s have no vaccine right now, right? So please remember that whatever you're learning, we will learn from you from the adult side in terms of transplanting COVID positive patients, because we will have the vast majority of them very, very soon.
Yeah. Okay. Well, thank you for staying, and we're thank our panel for a great discussion and talks. Thank you, Michael. Wonderful talk. And it gives me great pleasure to introduce my dear friend and colleague. I think he's probably one of the best speakers we have in hepatology or medicine. One of his groupies. Dr. Steve Flem will be giving a summary of this Liver Connect.
Thank you, Sammy. Every time he says that, I just reinforces the fact that I think he's insane, but it's okay. Most of us know that already, but I need the reinforcement. All right. First of all, I'd like to thank the advisors for attending this meeting. There's a lot of people attending virtually as well. I think this meeting has been a fabulous success, and I know Dr. Yanasi is going to say goodbye in a moment, but on behalf of the board of the Chronic Liver Disease Foundation, the Board of Trustees, would also like to thank everyone for coming. I thought the talks were excellent from start to finish, every single one of them. Not only has it been nice to get back together and see each other, we had over 80% of the advisors of the Chronic Liver Disease Foundation actually attend in person, which is an amazing number. And then we had really, really good talks, really from start to finish, keeping us updated in all of the different fields of liver disease, a whirlwind through liver disease, and help us care for our patients and teach our other faculty, fellows, residents, and everybody that we are dealing with back at home. They asked me to spend less than 30 seconds on each of the talks and just remind everybody what was discussed, or in case people missed any of the talks. Please note that my understanding is that these slides will be available online through the Chronic Liver Disease Foundation website. There may be something, if a particular speaker didn't want them to be available, that they can withdraw them, but my understanding is the slides will be available. So if you missed a talk or you were very interested in something, go through them. I actually just went through them myself this morning, and it's really good, the slides, really from start to finish. First of all, we were very fortunate to have Dr. Harvey Alter here. I've listened to Dr. Alter for doing talks for over 30 years. I have always said I think he's the single best speaker that I have ever heard in the field of liver disease. He did not disappoint. Thank you, Dr. Alter, for attending this conference and for everything you've done in our field. Even on a practical note, if you didn't do everything you did, most of us wouldn't even be here today because we wouldn't have anything to be talking about. Dr. Bernstein did an excellent job in talking about hepatitis C. Having an assignment to speak after Dr. Alter on the same topic is probably the single most difficult challenge one can have. And I was only disappointed, David, that there wasn't a single poem. I thought I'd get a roses or red, violets or blue one at least, but nothing. David talked about the World Health Organization elimination strategies, which are central to all of us who care for patients in liver disease right now. There was an emphasis on the importance of federal and state government activities in developing better strategies for elimination. Of course, David also highlighted that New York is the greatest. What a funny coincidence that is, that David lives in New York. But that was David's talk. Dr. Bob Gish did an unbelievably good job updating us on hepatitis B. He spent much of the time talking about new biomarkers, new factors that are important in our evaluation of hepatitis B, a little off the beaten path, more state-of-the-art than talks that we usually have. Of course, there was an emphasis on the risk of hepatocellular carcinoma and some of the therapeutic interventions and their favorable effect on the development of hepatocellular carcinoma. He finished talking about the 6 pillars of hepatitis B, which I think was one of the key slides in his presentation. And then at the very end, did a little summary on hepatitis delta. And we do have a new product or two forthcoming in the US, most likely for hepatitis delta. So I think there will be renewed interest in discussing this particular viral infection because we'll actually have something to do about it. Mike Lucy, as usual, gave an excellent talk on alcoholic liver disease, talking about defining the problem, mentioning the fact that, which has been reiterated several times, we're seeing more of that now in the COVID era than we ever really did. I think when you talk to everybody in the audience, you're seeing that all over the United States, which is kind of sad, I think, young people in particular. The impact of COVID on this presentation and how we need to get these patients hopefully back on track. There was an emphasis in Mike Lucy's talk on alcohol-associated hepatitis, which of course is important. Our current treatment strategies, which basically consists of corticosteroids, the fact that people with rapidly falling bilirubin might not require corticosteroids and that we should be judicious in our use of corticosteroids. And then some of the data on some of the emerging therapies. Then we had the fatty liver section of our talk, which is of our conference, which is of also very great importance to all of us because this is more and more dominating our practices. Mason Naured gave a very nice talk on the non-invasive tests that we now have available for detecting fibrosis in fatty liver and NASH, which will be important, of course, in identifying patients that are eligible for trials and then eligible for therapy. We had a very nice case presentation by speakers of different disciplines talking about cases that I think we all see in our practice and how we may evaluate them now and may evaluate them in the future. Steve Harrison gave a wonderful talk on the emerging therapies for fatty liver NASH, really identifying the different targets for intervention, kind of the pathophysiologic mechanisms of action of the different drugs, and then focusing on the different interventions that are currently in development and particularly in late development. And also, I think, talking very importantly about really trying to intervene high up. He talked about the cascade in terms of damage from beginning to end, with fibrosis being the end, and how important it is to really develop interventions that intervene at an earlier stage rather than waiting until the end. So that I thought was very helpful as well. We then moved to the cholestatic liver diseases. Chris Codley also gave a great talk, as he always does, both on primary biliary cholangitis and primary sclerosing cholangitis. We now know in PBC that alkaline phosphatase and bilirubin are markers, they're metrics that we should be following very closely for prognosis. This is evolving. 20 years ago when I was in fellowship, 25 years ago, really, we didn't think as much that alkaline phosphatase, we knew bilirubin was an adverse prognostic factor, but not so much with alkaline phosphatase, but it's becoming more and more clear that it is. Chris talked about obeticholic acid in PBC and some of the newer medications under investigation. And then he transitioned to PSC and reiterated the fact that many of us know that there is a frustrating lack of therapeutic options in this for this disease, even in 2021 still. I'm always actually, by the way, stunned about the lack of interest in pharma in trying to develop products for PSC. There just doesn't seem to be as much interest as I think there should. Bob Brown talked about thrombocytopenia, a vexing problem for all of us when procedures are necessary in patients with advanced liver disease, portal hypertension, and splenic sequestration of platelets. Bob talked about platelet transfusions and the travails that presents, and then talked about the newer thrombopoietin agonists that are now approved for this indication in patients with chronic liver disease and thrombocytopenia with a planned procedure and the possible positive effects that entails. Today, hopefully everybody was able to hear all the talks today. Jaz Bajaj also gave his usual fabulous talk on hepatic encephalopathy, how to deal with refractory encephalopathy, which was the title of his talk. And then he said it doesn't actually exist, but then he talked about it for 25 minutes. We all know readmission of these patients is extremely common. Mismanagement of these patients causing more readmission is extremely common. Jaz actually had some very good points. That checklist slide that he had on there, I think, was very important. It's a good one for when you teach residents and fellows about HE for you to highlight, I think, because I don't think we spend enough time talking to patients. We're in a hurry, and their families. We're in a hurry. We're trying to do the best we can, but a few extra minutes talking to patients who are inpatients with HE actually can really change, I think, some of the outcomes, because the management of those patients would be much better. And also, Jaz, other main take-home message for me was that these patients need to brush their teeth better. Hugh, right, Jaz? Is Jaz still here? He didn't like their dental, that our care of their dentition. Hugo Vargas talked about hepatorenal syndrome, talked about the changing definition of that. I actually don't think a lot of GI liver doctors are locked in on the new definition of hepatorenal syndrome. And we really need to kind of move forward in using that definition correctly. And then talked about the current US management, which is with all unapproved products. And then talked about the data on terlipressin, which is currently under review by FDA and hopefully will be available here for us to use in appropriate patients like it is in dozens of countries in the world. Mike Charlton also gave an excellent talk on liver transplantation, talking about the history of transplant, talking about many of the very current issues that are pertinent in liver transplant, HCV in liver transplant, HIV in liver transplantation, heart liver transplantation. He mentioned the new allocation system, living liver donation, what else? Alcohol transplantation for alcohol-associated hepatitis, and then talked about machines. And we will be talking about machines more a little bit on the perfusion side and increasing, hopefully, organ availability. Dr. Coley gave an excellent talk on pediatric liver transplantation. You know, we in the adult world don't talk too much about this. At Northwestern, where I am, we have a very good liver transplant center for children across the street, but we don't talk too much about it. It's very important. And these patients are doing better and they're transitioning into the adult world than they used to, both with diseases like biliary atresia that had Kasai's before liver transplant and patients that have had liver transplant and are doing well and then come to us in the post setting. So excellent talk about many of the pertinent issues there. Raj Reddy gave, I thought, too, an excellent talk on COVID, talking about the possibility of COVID and liver toxicity or liver damage from COVID, and then a lot of the different aspects of COVID in terms of patients with defined liver diseases like hepatitis B and hepatitis C, cirrhosis, and post-liver transplantation. Of course, this is an emerging body of knowledge. We will learn more when we hopefully have Liver Connect next year. I think that talk will be greatly updated and we'll have a lot more very important information that really affects our practice every single day. And vaccination too, by the way, in COVID is an important issue. We just had a patient, by the way, with autoimmune hepatitis who was vaccinated for COVID and 2 weeks later had a flare of autoimmune hepatitis with liver enzymes over 1,000 and biopsy proven recurrence of autoimmune hepatitis. This of course is not a new revelation, but we hadn't seen it directly with COVID before. And she was on Imuran. She had been on for years with no activation, years and years on maintenance therapy with azathioprine, and then required corticosteroids again. And it's back under control pretty quickly, but it shows again some of this vaccine-related issue. And then finally, Laura Kulik from our center at Northwestern, who gave an excellent talk on hepatocellular carcinoma. This too, hepatocellular carcinoma is also troublesome for everybody in the audience. When I first started as an attending 25 years ago, we didn't see very much hepatocellular carcinoma. It was there, but now, as everywhere else, we see it all the time. We see it all the time. And Laura talked about the very important recent approval of radioembolization for this entity. Dr. Salem's group, and Dr. Lewandowski, these are the interventional radiologists at Northwestern. Laura has been instrumental in doing a lot of these trials over the last 15 years. It works. I'm sure you guys have all seen it work, radioembolization, and I'm glad we finally moved forward with approval. And then Laura really finished with a tour de force around what to do with patients that are out of Milan criteria for liver transplant, and talked about many of our therapeutic options, what some of the new research strategies are in this field to help downstage patients for liver transplantation. And if you can't downstage patients for liver transplantation, how do we best choose therapies that optimize their survival? Because there are ways to do it. Again, with these new therapies that are out, we don't know everything yet. But with all the studies that are ongoing and more to come, we're learning better how we can provide an ideal therapeutic or an individualized therapeutic approach to a particular patient. So with that, I'd like to thank everybody again for attending. Dr. Yanasi is going to come up too and say goodbye. It's my hope that there will be a meeting like this next year again. I'm sure there's going to be an evaluation, and please tell us what we did right and what we did wrong, because we want to make this better, and we want everybody to join again. Thank you.
Thank you very much, Steve, for the wonderful summary. I'm not going to take more than 2 minutes just to thank you all for attending here. And we had actually about 300 people even this morning joining virtually. So this was, in my view, was a successful meeting. We had great venue here. And I want to thank not only the faculty here, but also our sponsors, because our sponsors really are the key folks for us to make this happen, obviously. We are actually going to have a 2022 Liver Connect. The meeting agenda started this morning, so keep your program at least open, hopefully about the same time. The venue has not been decided. We will have that, maybe a slightly different format than what we have today, probably even more improved format. We have CME, of course, available for all of you to take. All the presentations are actually taped, not only actually slides, but they're also taped. This is because folks from Asia asked us to come back and actually listen to the meeting when it's not 2 o'clock in the morning. So you can go back there as well. And finally, I just want to thank the CLDF and Focus Medical again. I think these are incredible people, incredibly hardworking, competent, and really we cannot have any of this without their support. So, and the 3 people that I always want to sort of mention, just because, and it's not just limited to the 3 of them, is of course, folks who actually put this program together with Steve Flam and Steve Flam's team, and also our liaison to the board, Krista Smith. So Danielle, of course, who actually organized this entire meeting single-handedly. So thank you all. See you next year, and enjoy this wonderful resort for the rest of the day.